Test. Distinguished guests and colleagues, welcome to day 2 of our conference. We are pleased to begin today's program with session focusing on one of the most impactful metabolic diseases and the latest therapeutic updates in its management. My name is Rinad Farhan Al-Gahtani, PharmD candidate at King Khalid University, founder and the president of Tabassur Initiative. It's my pleasure to introduce this session. Today's sessions will focus on type 2 diabetes mellitus, highlighting recent updates. The session includes 3 lectures. First, enhancing national healthcare resilience through insulin localizations in Saudi Arabia, and that will be presented by Dr. Mustafa Al-Jawadi. So please join me in welcoming Dr. Mustafa.
Bismillah ar-Rahman ar-Rahim, wa salatu wa salam ala Sayyidi Rasulillah. Let me start by thanking the organizing committee to give me the chance to speak about insulin localization, try to explain the complexity behind insulin localization, and be very proud to say that Sanofi and Novo Nordisk has managed to secure what called insulin localization. It's a very complex, and we are very proud to say that it's already done in Saudi. So today, we can say with full pride, we have insulin made in Saudi. I want to start by saying this is the first insulin that was produced in 1923. So we're talking about 102 years ago. This is the complexity, how it starts. And today we feel very proud that we went over these years from what you see to a very advanced level that serve our patient, our community, and take us to the next level. This started in our manufacturing site in Germany at 1923, and we always count in the history that led us to today. Without the history, we will never be here today. So, Vision 2030. Today, Vision 2030, it's something we feel as Saudis very proud of. Localization of the pharmaceutical is a crucial part in the localization and the Vision 2030. Part of that is the insulin localization. You all know that the Royal Cabinet have established a committee headed by the Minister of Industry to localize insulin and vaccines. And today, as part of the Vision 2030, we are very proud to say we managed to localize 4 of our insulin in the country, Toujeo, Lantus, Abedra, and Siliqua. This is part of the global direction to have insulin, to have security in the country. So we managed to build up that in Saudi. We also took it further. We have the bin assembly also here in Saudi. Our partner is Sudair, where we have a partnership with Sudair to establish our manufacturing site, full manufacture, full cycle. So for all those who want to be asking what kind of level of localization we're going to have, it's the full cycle. And I want to share something that I feel very proud as a Saudi. Today, our localization in Saudi is the full cycle of localization. We're not doing packaging, we're not doing primary, we're taking it the full cycle of localization of insulin. Sanofi have sites in Germany, in Russia, and in China, and in Saudi. The only site that have full cycle outside Germany is Saudi. So basically, we have a full transfer of our technology to Saudi, and we feel very proud and honored to have this in our country. Our investment reached beyond 360 million. What it will add to the country, it's not only the investment of the full cycle of insulin, but no, there are going to be high-tech jobs that will be covered by Saudis, and all that will be in addition, on top of what we're doing. So basically, in a summary, I would like to say is that we secured to bring the full cycle localization of insulin in Sudan, in Saudi, and this is part of the Vision 2030. And we all understand and believe, especially after Corona, that drug security is a red line for the country. And we're very proud to say we're part of this today. On top of that, what are we adding to the patient? Our patient is going to have access to the best-in-class insulin. Secondly, what we are doing is the tech transfer, the local capabilities we are building in investment in Saudis, in these sites, because basically insulin manufacturing, it's a high-tech process that needs high qualification on the ground. What we are also doing on top of that is working with the healthcare provider in raising the awareness of diabetes in the country, taking it to the next level, working with the Diabetes Society to improve the understanding of diabetes, keeping everyone updated about what's going on in the world of diabetes. We also managing to bring a lot of patient support and education through different technologies to the patient, where it tells them, you know what, it's time for your insulin. It's the time that you need to go and take your insulin. All these is what we call it insulin localization. It's not only the site, it's not only the machine. No, it goes way beyond that. A dream started, a lot of discussion, a lot of negotiation, and we managed in 2024 to sign our MOU. So that was the first commitment to come to Saudi, is by signing our MOU. You know what? A couple of months later, we did our manufacturer inauguration in Sudan. We were honored to have the Minister of Industry and high-level governmental officialing to witness the historical moment of insulin localization in Saudi. Today, this is the picture just a couple months ago. This is our site moving very fast in order to complete this project. Hopefully, by end of 26, this site will be live, and we plan also to have our manufacturing production out by 27. So it's a journey, it's a commitment. We are very proud to say we are in the right direction to build that. That means that we're going to have easy access to our insulin. We're going to have the drug security to our insulin. We don't need to bring anything from outside. It's all going to be insulin made in Saudi. In a summary, any manufacturing site in Saudi have so much inside it, so many different meanings, starting from transfer of technology, especially if you go big in our manufacturing. Today, we have transfer of technology. We're bringing the cooking book all to Saudi, where that is only secured in one site in Sanofi in Germany for 100 years, no access to it. The only country that managed to bring that cooking book is Saudi. We have it in Sudair. It's going to be part of what we bring it. We're going to be taking the 150 jobs we're going to create, high-tech level to the next level. We're going to bring our experts to raise the bar on the capabilities of the team of the people. Our manufacturing site will produce 50 million pens annually. And I want to focus on one thing on this number. And I want to share the big decision that Saudi did to bring insulin localization in the country. Our manufacturing site in Frankfurt produces 1 million pen per hour. So basically, 1 day and a half, I cover Saudi. 2 days, I cover the whole GCC region of production. So it's way cheaper to keep the manufacturing site there and not to transfer it. So the message said, we took the decision to bring up everything here in Saudi, despite the volume is 1 day and a half of what Frankfurt is doing. But it's the drug security we want to build in the country. It's our commitment to the Vision 2030, and this is what we want to see on the ground for the future. By this, I conclude my presentation. If anyone have any questions, we will be more than happy. Okay. Thank you.
Thank you, Dr. Mustafa. So let's continue our lectures. The second session is about type 2 diabetes mellitus management, updates, and the new insulin formulations. That will be presented by Dr. Fatma Al-Jahani. The third one, update of weight reductions medication, therapeutic updates, and post-marketing pharmacovigilance, and that will be presented by Dr. Ala Abu Zaid. Before we begin, it's my pleasure to introduce the moderator of this session, Dr. Mohammed Al-Shehri, BGY1R2 clinical pharmacist resident at Security Forces Hospital. At this point, please join me in welcoming Dr. Mohammed Al-Shehri. Dr. Mohammed, the stage is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Rinat, for the nice introductions. Good afternoon, everyone. Honestly, it's my pleasure to be in here with you today, as well as it's my pleasure to moderate such an important and valuable sessions, well presented by our distinguished speaker as a part of Ihop second conference. As Dr. Rinat mentioned, this session includes 2 lectures. The first lecture will be presented by Dr. Fatma Al-Jahani, and the second lecture will be presented by Dr. Ala Abu Zaid. Now let's start with our first speakers, Dr. Fatma Al-Jahani. It's my pleasure to introduce her. Dr. Fatma Al-Jahani is a consultant clinical pharmacist specializing in internal medicine at Prince Sultan Armed Forces Hospitals, Al Medina, where she also serves as a director of a clinical pharmacy residency program at Armed Forces Hospitals in 4 training sectors. With a career spanning at the same institution, she has progressed from a pharmacist to senior clinical roles and leadership positions, including deputy director of a pharmacy. Dr. Al-Jahani graduated from Al-Qura University and completed her clinical pharmacy residency through the Saudi Commission for Health Specialties, including training at Johns Hopkins Aramco Healthcare and Prince Sultan Military Medical City. She is board certified ambulatory care pharmacist. Her professional contribution extend to research, education, and she is frequent oral presenters on clinical update in diabetes, obesity, and pharmacotherapy. She actively contributes to pharmacy community through volunteering and participation in a major conference. Now, it's my privilege to invite Dr. Fatma to the stage. Please join me in a warm welcome and appreciation.
Good evening, everyone. Thank you, Dr. Muhammad, for introducing me, and I would like to thank the organizing committee for inviting me for this talk. Here's my disclosure, and my objective for today will be we will discuss and understand the current challenge and opportunity in management of type 2 diabetes and review the latest ADA guideline recommendation for management of type 2 diabetes, and we will review the new insulin formulation, including kinetic and clinical application, and finally we will discuss regarding the future direction of diabetes management and implication. So before we dive in exciting update in type 2 diabetes management and the new insulin formulation, I want to highlight a critical issue here as we see this data from the International Diabetes Federation. As we see here in 2000, we were with less than 1 million people diagnosed with diabetes. But if you see the progression in 2024, we are living with more than 5 million of people with diabetes, and we are looking for 9 million of adult patients with diabetes in 2025. Actually, this trajectory puts Saudi Arabia among the high and growing countries with a burden of diabetes. Let's break down this current critical challenge in diabetes. First, suboptimal glycemic control. Suboptimal glycemic control remain essential factors that, despite our effort in controlling, we have a lot of patients did not achieve their individual A1C target, and this leads us to the second challenge, which is recognizing the delay in optimizing treatment for those patients. This delay can be overcome before they are reaching cardiovascular and renal complication. Weight management now is a central pillar. And the most of patients with type 2 diabetes, unfortunately, they cannot maintain the weight loss. Hypoglycemia risk is a barrier for those patients, especially in insulin therapy. So this is a barrier for the effective management of those patients. And none of our strategies matter if those patients cannot afford this. So ADA guideline recommendation provide us evidence-based roadmap. The recent guideline 2026 was published a few days ago, and it's emphasized on patient-centered approach and comprehensive risk reduction. Also, organ protection, like a cardiovascular focus and renal protection, weight management, and also emphasize in using the technology integration, especially continuous glucose monitoring for type 2 diabetes. So moving to the ADA guideline, the target was the same, was not a change, but they integrate the time and range for all patients because we need to intensify and optimize the management. Keep in your consideration the different factors that influence the target, such as age, life expectancy, comorbidity, and quality of life, and risk of hypoglycemia. So regardless of baseline A1C, if the goal cardiovascular and kidney protection, we need to start with SGLT2 inhibitor or GLP-1 receptor agonist for all patients with having atherosclerotic cardiovascular disease or having indicator of high-risk cardiovascular heart failure and CKD. A new recommendation made here in the recent guideline to start SGLT2 inhibitor or dual GLP-1, GLP-2, dual GIP and GLP-1, which is tirzepatide, or GLP-1 with proven benefit for patients with symptomatic heart failure, preserved ejection fraction, and obesity. For renal patients, just keep in your mind that the glucose-lowering efficacy is reduced when the GFR is less than 45. So in this case, we may prefer GLP-1 receptor agonist with a proven benefit in chronic kidney disease. Moving to the weight management and glycemic control. So I will not speak about weight management since Dr. Ala's lectures will be about weight management. But in general, semaglutide tirzepatide considered as high efficacy medication for achieving and maintaining glycemic goals. Here's the role of metformin and other therapy is placed. Additional to the cardiovascular and kidney risk reduction, the management of other metabolic comorbidities, such as metabolic dysfunction-associated steatohepatitis. So the guideline recommend to start the medication with a proven benefit, such as GLP-1 receptor agonist, GIP, and GLP-1 receptor agonist, such as tirzepatide or bioglitazone, or combination of GLP-1 receptor agonist with bioglitazone. And we need to keep in our mind that only semaglutide was FDA approved as for the metabolic liver disease. So despite all of these medication, unfortunately, none of oral therapy or injectable even proven to protect beta cell failure. So at any time, the patient presented with a severe symptom of hyperglycemia, A1C more than 10, or high blood glucose level more than 300, insulin here is still on the list. So according to the ADA guideline to start insulin therapy, and the new here in this update, the guideline gives us initiation and titration strategy to optimize and to reduce risk of hypoglycemia. To start with a basal insulin, and if this basal insulin is still not reach, if the patient is not reaching glycemic target, the guideline recommend to add dual agonist or GLP-1 agonist if the patient is still not used it before. After that, we can move to add prandial insulin, and the guideline also give us a recommendation for initiation and titration. Unpredictable absorption, peak time issue, and risk of hypoglycemia, short duration of action, all these as a limitation for conventional insulin. And now, these days, we are moving to the new era of insulin therapy. We are moving from only insulin hormone replacement to a sophisticated engineering molecules for insulin. So regarding the ultra long-acting insulin, such as insulin degludec, insulin icodec, a once weekly, or insulin efsitora, and also we have concentrated formulation which help for those patients requiring a large volume of doses. And also we have ultra-rapid insulins such as insulin aspart, Fiasp, insulin lispro, Lomjev, and the inhaler. Also, we have fixed ratio combination. It's combination between long-acting insulin and GLP-1 receptor agonist. So starting with the first ultra-long insulin, diglodic, the study showed when compared to glargine, there is non-inferior in A1C reduction and cardiovascular benefit. Also, there is similar baseline glucose A1C, and there is significant reduction in hypoglycemia for this group on diglodic. Moving to the once weekly, actually this formulation was marketed in Canada, Europe, and under brand name Weekly. It's bioengineered to form an albumin-bound depot, which is leading to gradual release of insulin. But the extended half-life for this medication around 7 days. It's allowed for once weekly and reduced treatment burden for those patients. Among all trial onward clinical program, ECODIC shows a similar A1C reduction and similar hypoglycemic risk when compared with different comparator. Moving to the second once weekly insulin Efsitora. Efsitora is a fusion protein combining a novel single chain insulin variant to a human immunoglobulin, and it's characterized by a very long half-life, around 17 days. So in the studies, the dosing were different from study to other. So some studies recommend to start with loading to achieve a steady state sooner. So among all trial of QUINT program for type 2 diabetes, it shows there's similar A1C reduction and similar hypoglycemia risk. So the main advantage for those once weekly formulation is to reduce the injection burden on treatment. Moving to ultra-rapid acting insulin formulation, it's bioengineered. It's the same as rapid, but it's insulin aspart, but it's bioengineered by adding absorption enhancer, L-arginine and niacinamide. Let's make this a faster of action. And according to onset study program, it gives us a comparable A1C reduction with a significant improvement of postprandial glucose in first and second hours, and there's similar severe hypoglycemia rate. So the main advantage for this ultra-rapid to give it for those patients having high blood glucose after a meal. The second ultra-rapid is insulin lispro, Lomjev. It's the same with aspart. And it gives us a flexibility in meal timing and dose duration, and its dose and frequency even. The key outcome of the Pronto trial showed there is non-inferior A1C reduction with improvement on postprandial glucose and comparable hypoglycemic risk when compared to conventional lispro. The last part of my presentation is about the fixed ratio combination. It's combination between basal insulin, ultra-long or long insulin, and GLP-1 receptor agonist. It gives us a product with a balanced weight and reduce hypoglycemia and improve GI tolerability. This fixed ratio combination overcomes the adverse effect of individual component. Starting with the first one, insulin glargine lexinatide, Siliquats, available almost in all hospitals now. The study Lexilan trial outcome, when they compared insulin glargine with lexinatide versus insulin glargine alone, it gives us a superior A1C reduction, of course, because it's combination of two medication. And here we can use this medication in the guideline if the patient not stable, still need further reduction in blood glucose while in insulin, and beneficial effect on weight with comparable hypoglycemia risk. The second fixed ratio combination, insulin diglodic ultra-long with long-acting liraglutide, also the same finding, superior A1C reduction and beneficial effect on weight, and for regarding hypoglycemia, it's the same. This combination of insulin, long-acting insulin with rapid-acting aspart, this can be used to reduce the burden of pill, long-acting and rapid-acting. It shows also superior A1C reduction, but very important to counsel the patient and to use this insulin with meal. And the rate of nocturnal hypoglycemia was not significant. Also, the rate of overall severe hypoglycemia. Insulin icodiec, once weekly and once weekly semaglutide under the brand is Icosema. Actually, this is ultra-long, once weekly insulin combined with also long-acting GLP-1 agonist aim to simplify the treatment for adults with type 2 diabetes. According to the combined trial, all the patients reaching the target, and actually it shows a promising option for management of type 2 diabetes and also reduce the injection burden. Finally, we need to assess for hypoglycemia risk management, medication reassessment protocol at initiation. Avoid any medication having a high risk of hypoglycemia, such as sulfonylurea, and insulin if the patient having high risk. And to minimize the risk of hypoglycemia, we need to act as a proactive medication assessment that will help us to reduce the hypoglycemia risk and improve treatment adherence. This is my talk, and just remind that we are moved beyond the A1C and prioritize the patient with a cardio and renal metabolic benefit. Insulin still remain on the list, but however, it's positioned now after the GLP-1 agonist or in combination, and the key goal to reduce the burden of therapy and improve safety. And remember to individualize and integrate and personalized treatment. Thank you.
Thank you, Dr. Fatma, for this insight presentations. And now we will move to our second speaker, Dr. Ala Bouzaid, and it's my pleasure to introduce her. Dr. Ala Bouzaid is a board-certified clinical pharmacist specializing in ambulatory care and medication therapy management. She holds a Doctor of Pharmacy degree from King Abdulaziz University in Jeddah and graduate diploma in advanced pharmacy practice studies from Massachusetts College of Pharmacy and Health Sciences University in Boston. She completed her PGY1 clinical pharmacy residency at King Abdulaziz University Hospital, followed by a PGY2 residency in ambulatory care at King Saud University Medical City. Dr. Abu Zaid has trained in excellence-driven healthcare and environment and gained clinical experience across anticoagulation, medication therapy management, geriatric, and diabetes clinics. In addition to her role, she served as preceptors and mentors to the next generation of pharmacists. She previously served as clinical pharmacist at King Abdullah Medical City in Mecca, and currently she practices at King Abdulaziz Medical City, National Guard, Jeddah. Please feel comfortable, stay engaged, and benefit from the lecture. Dr. Ala, the stage is yours.
Thank you for the introduction, Dr. Muhammad, and thank you all for attending, and good afternoon. So today, my talk is about modern anti-obesity pharmacotherapy, practice-changing evidence, and safety insights. طيب كده البوينت. So I have nothing to disclose. Okay, so I'm going to go through first what's new, focusing on GLP-based therapies, then what's matter, translating evidence outcomes to practice, and finally what's safe, looking at the post-marketing safety and pharmacovigilance. So if we look at the current approved injectables for obesity, as we know, there are three: the liraglutide 3 milligram, the semaglutide 2.4 milligram, and the tirzepatide 5 to 15 milligram. And if we look, take a look at our clinics today, I'm sure, or even in personal life, we would see how common the prescribing GLP-1 therapy for obesity. You will see that it's pretty much common. Globally, it's increasing by a rate of 20 to 30% annually, driven mostly by obesity indication. Of course, most of the data are driven from North America and Europe. However, in KSA, we all know that there is a high prevalence of obesity. So why GLP-1 based therapy? If we took a look at the comparative efficacy of various interventions for obesity, we would see that the injectable GLP therapy effectiveness of weight reduction ranges from 6 to 21%, which is if combined with lifestyle intervention, that would actually reach the bariatric surgery efficacy, which is the currently most effective procedure or most effective intervention for obesity. Let's take a quick overview of the approved indications, contraindications, and warnings across the various bodies, regulatory bodies in North America, Europe, and the Saudi FDA. Starting with the first approved one, the liraglutide or the Saxenda 3 milligram. You might notice first that the indication now, the FDA indication removed BMI-based indications. It's now more expanded for the expanded obesity definition. The contraindications are still the C-cell carcinoma risk, and we want to see that there is a difference between this agent and other agents in the discontinuation cut line. It is mentioned if there is no insufficient response, so after 16 weeks or 12 weeks. And it is the only one approved for children in Europe from 6 to 12 years old. For the updated warnings, we would see that the FDA added severe gastroparesis and also aspiration association pneumonia in the warnings. And the history of suicide ideation risk actually is only in the FDA warning, not yet adopted by European regulators. Saxenda is registered in the Saudi FDA for weight reduction. Moving to the semaglutide or the Wegovy 2.4 milligram. Of course, the update for the updated indication. It's mentioned the cardiovascular risk reduction. It's also adopted in the UK labeling. And for the contraindication and warnings are similar to liraglutide with the added of diabetic retinopathy complication. It's also registered in the Saudi FDA for weight reduction. Moving to tirzepatide or Manjaro, Zepbound or Manjaro from 5 to 15. Here, the most updated indication update is the moderate to severe obstructive sleep apnea use. It shares similarities with the contraindication and warnings with the other two. However, they did add the decreased hormonal oral contraceptive efficacy. This is mostly due to interruption of absorption due to lower GI motility. It's also approved in the Saudi FDA for weight management. And to help in relieve the shortages that we have and reduce the cost, we would need generics. So first approved generic is Saxenda, approved in the US. And what's in the near pipeline? Here we're talking about expected approvals in 2026, the coming year. So we have a triple agonist combination with glucagon, the retatrutide. We also have the survodutide. We have combination with amylin, the cargisema. And we have the oral GLP agonist approved for obesity. It might be approved in 2026, the orforglipron. Okay, moving to practice-changing evidence. So what matters from the global guidelines? First, we need to note that they did expand the obesity definition beyond BMI. Now it included this term, the obesity-based chronic disease. And in this wide umbrella, it actually addresses health outcomes and complication of obesity, not only BMI. And in this regard, we have the well-known SELECT trials, which is the semaglutide and cardiovascular outcome in obesity without diabetes study. And this study is a multicenter randomized double-blind placebo-controlled trial that included 17,000 patients with established cardiovascular disease, and they met the obesity BMI definition. And they compared semaglutide 2.4 milligram to placebo, and the outcome was time to first MACE. In the SELECT trial, semaglutide 2.4 milligram showed superiority to placebo for the 3-point MACE, and which was reduced MACE by almost 20%. Is it the same? Sorry. Yeah. So is it the same for tirzepatide? It did make the non-inferiority margin for patients with diabetes and cardiovascular risk when compared to dulaglutide. However, the study for obesity is the SURMOUNT MMO trial. We're anticipating this result. It is done for obesity patients without diabetes, and it included patients with or without cardiovascular risk. So here we're talking about primary and secondary prevention of cardiovascular disease. It's currently in progress, and the primary outcome would be 5-point MACE. Therefore, all the cardiovascular societies now endorses semaglutide 2.4 to reduce MACE in patients with overweight or obesity. However, in tirzepatide, it is recommended for weight loss in cardiovascular disease patients. So if we take a look at how these three injectables are ranked among international guidelines, we would see that semaglutide is a first line for its established weight loss and cardiovascular benefits. Something rapidly moving to co-first line status is the tirzepatide with the maximal weight loss efficacy and metabolic benefit, while liraglutide is increasingly positioned now as second line or alternative therapy. So we can use it as if the first two agents were not available, or if only mild weight reduction is required. So moving to what's safe, here, as we know, new approvals that meet emerging post-marketing safety and pharmacovigilance data. I'm focusing on updates on pulmonary aspiration risk, neuropsychiatric events, and GIT motility issues. So just to explain some of the off-target effects of GLP or the adverse effects, some fact is that now obesity is a chronic condition. Therefore, the use is expected to be long-term, especially when lifestyle alone is not sufficient. Also, there's the fact that GLP receptors are widely distributed in tissues such as the brain, pancreatic B cell, kidneys, and thyroid C cell. And additionally, the fact that the off-target effects are mostly linked to the potency of GLP receptor agonists, or it's dose related. However, we have limited safety data for observational and retrospective data. So starting with first with the updated labeling, FDA labeling for semaglutide, we will see that they did add severe gastroparesis, avoid in severe gastroparesis patients. And if we see the pneumonia aspiration risk, we would see that many societies of anesthesia, they do adopt the fact that we can continue GLP therapy pre-operatively. However, we should identify high-risk patients, those especially at the first phase of dose escalation or having severe GI symptoms. And for those patients, we can follow liquid-only diet 24-hour before surgery, or we can delay surgery, if possible, till the risk is minimized. There is the controversial risk of suicidal ideation link, and we would see that up until 2024, the regulators, RCT, and large observational studies showed no causal link between GLP therapies and suicidal risk. However, monitoring is advised in patients with with history of severe depression, suicide, and patient at high risk of psychiatric illness. As a rule, discontinue GLP-1 based therapy whenever we have severe adverse effects, whenever there is pregnancy, and it should be stopped several months pre-conception. For early non-responders, and this is usually defined as patient with less than 5% weight reduction initially. And we should always emphasize monitoring and slow dose escalation, especially for the obesity indication, reporting of any emerging adverse effects, and patient education. So to wrap up, we will see that modern GLP, GIP therapies are now considered a first-line agent for obesity. And therapy must be individualized. Here we should take a look at the comorbidity status and local access yes. Semaglutide and tirzepatide are currently first-line agent due to the favorable effects. And the fact that therapy is long-term, with that we should emphasize titration and monitoring, education, adherence, and reporting. Clinicians should stay vigilant for any long-term safety, emerging long-term safety data. And that's all. I highly advise you to visit the most recent AACE algorithm for managing obesity. It contains helpful diagrams and tables to help you in the decision-making process. These are my references, and thank you.
Thank you, Dr. Ala, for this informative lectures. Dr. Ala and Dr. Fatima, please join me on the stage. And now we will open floor for questions. If anyone has any questions, feel free to ask. Mike.
Dr. Ala, thank you very much for the fruitful lecture that you presented. My question actually is about a new GLP-1 that I just knew about it when I visited Germany this year to CPHI. It's a, CPHI, it's like a conference that happened to be every year. This year, it was in Germany. So I was actually with a Korean company, and this guy, he has a new GLP-1, it's called coraglutide. It's an oral form of GLP-1. And he claims, and he has done, he showed me all the literatures that he has done about it. And it has the most weight reduction among all the GLP-1s. It's an oral one rather than being injectable. It's an oral. And he told me that it's registered in Saudi Arabia. And it's a food supplement rather than being a medication or a pharmaceuticals. So my question to you, like, do you know anything about it, or have you, when you did your research or your presentation, have you found any information about this kind of medication? Thank you.
Thank you, Doctor, for the question. I'm not sure if you mean it's approved for other than obesity indication, maybe for type 2?
It's on, no, actually, according to what he told me, that's only for obesity. And that guy, actually, he's the owner of the company. And he informed me that he became a actually, he told me he's a billionaire right now for about 2 years, the past 2 years, because of the selling of this medication, because he's selling it to so many countries as an oral medication once daily. And the price is for 36 pills around $100 retail. And he told me if I want to buy, let's say, 20,000 pieces, he will consider it by $30 a piece, like in 36 capsules.
As we know currently in KSA, we have only this injectable GLP therapy based approved for weight reduction up until now. Up to my knowledge. So, however, as we saw, 2026, many new agents will enter the market. So maybe it's one of them. Again, the approvals differs from the FDA labeling, and you have Europe and UK. So again, maybe it will be approved there, and then in KSA, I'm not. This is my type.
Okay, thank you.
Thank you.
Fair enough.
يعطيك العافية دكتور علا. Thank you so much for your interesting talk. I would like to ask about the part that you have explained that MACE are reduced by GLP-1 agonist, right? In the cardiovascular complication or outcome.
Yes.
Is that explained only by weight reduction? I mean, those studies have looked at the weight reduction component by which it reduces mortality or cardiovascular event. Because my question is it only by losing weight they are actually having better outcome when it comes to MACE, or the class possess extra, cardiovascular protective mechanisms or properties?
Thank you for the question. As we know, the SELECT trial is the first trial done that included obesity patients only without diabetes. And the fact that it showed the cardiovascular benefit is promising for other GLP agents. However, we still don't have the conclusion. I mean, the trials are still ongoing currently. As for cardiovascular risk, as we know now, as the term of obesity has expanded, not just to reduce the weight or to look at the number or the BMI. We should look at the patient as a whole, including the comorbidity status or obesity-related cardiometabolic complications. And because the obesity has this relation, it might explain why the GLP therapy helps in reducing the risk. However, I mean, one of the trials, the one upcoming for the tirzepatide, and other trials are ongoing for other GLPs, and that's really, it might show promising result in this regard.
شكرا.
يعطيك العافية دكتور آلاء. Just a question, what about combination for the SGLT2 inhibitors combined with the GLP-1 for those patients with established cardiovascular disease? Can we combine them, or is there any criteria to specify use of this recommended two options?
Thank you for your question. Actually, according to the guideline, there is no criteria, no contraindication to prescribe them together. Actually, the guideline recommend to start with one. If the patient is still not reaching the target hyperglycemia A1C, so you can add the second medication.
So it can be considered for those obese patients with established cardiovascular disease to start the GLP post of the SAS, for example. It can be started post of the SAS for any obese patient, GLP-1.
Yes, actually it's recommended as first line to reduce cardiovascular obesity and kidney protection.
Without any contraindication to use with the SGLT inhibitors in relation to the A1C. If the patient A1C is not high, for example, it can be considered. So obese patient not diagnosed with diabetes, for example, can we combine them?
So SGLT inhibitor, it's not approved for obesity. It's only for diabetes.
Yes.
Yeah. So I did not get your point why you want to combine them together while the patient is not diabetic.
So I mean, for obese patient, we can consider use of the GLP-1 from the beginning, post of the SAS, to reduce the baseline patient weight. It's okay. I mean, is there any complication to combine them in the hypoglycemia incidence, for example, because both two options antidiabetic agents? Is there any evidence related to the complication for this side effect or no?
Regarding the contraindication to combine them together, there is no contraindication, but you need to consider each medication contraindication, and you need to monitor those patients frequently.
Thank you.
I would like to ask Dr. Fatima, are there specific patient group where these new formulations is not appropriate or may not appropriate for them?
Yeah, sure. For the once weekly, for example, for once weekly formulation, we need to start this medication for those patients who are compliant to the medication. And those patients need to be compliant because it's difficult to remember this medication as to be given at the same time every week, and how to deal with this medication maybe need to dosing error.
يعطيك العافية دكتورة. By the end of our sessions, I would like to thank our distinguished speakers and the audience for your participations as well. We hope you found these sessions informative and beneficial. Thank you all.
At this time, as we conclude this session, we would like to take a moment to recognize and appreciate the valuable contributions of our speakers and moderator, whose expertise and insight greatly enriched today's discussion. We kindly invite Dr. Ala Matlaq to join us on the stage. First, we would like to invite Dr. Fatma Al-Juhani to the stage. Thank you, Dr. Fatma, for your excellent delivery, clear clinical insight, and for sharing a practical perspective that added insight value to this session. And we would like to invite Dr. Ala Bouzey to the stage. Thank you, Dr. Ala, for your informative contributions and for enriching the discussions with the valuable insight. On behalf of the scientific committee, we also extend our sincere appreciations to our moderator, Dr. Mohammed Al-Shihri, for his professionalism and for leading the session smoothly and effectively. Thank you all, and we hope this session has been valuable.
Have a pre-break. We will start, inshallah, 1:35. 25. Sorry, 1 and 5 minutes. 1:05. 1:05. 1:05. 1:05.
Good afternoon, everyone. Ladies and gentlemen, distinguished guests, welcome to Session 8, Pharmacy Practice Research, Sharing Experience and Establishing Benchmark. My name is Ziad Saeed Al-Ahmari, a pharmacy intern from King Khalid University, and it's my pleasure to introduce this session. In today's session, we will explore how pharmacy practice research supports clinical decision making, improve patient outcomes, and contribute to the development of evidence-based benchmark across healthcare system. This session brings together expertise in pharmacy practice research with perspective focused on translating research experience into meaningful and measurable clinical benchmark. Our speaker for this session is Professor Majd Al-Jaraisi, who will share practical insight and experience in advancing pharmacy practice research. And to guide this session and ensure a focused and insightful session, we are honored to have a distinguished leader in cardiovascular pharmacotherapy serving as our session chair. Our session chair is Dr. Abdulrazak Al-Jazairi, is clinical pharmacy consultant specializing in cardiovascular pharmacotherapy and director of Clinical Trials Transformation Division at King Faisal Specialist Hospital and Research Center in Riyadh. He earned his Doctor of Pharmacy degree from Campbell University in the United States, completed his general practice residency at Duke University Medical Center, and later pursued a 2-year specialty residency in cardiovascular pharmacotherapy in Philadelphia. Dr. Jazairi has authored more than 50 original research publications, delivered numerous national and international presentations, and is the founder of the Saudi Clinical Pharmacy Society. He served on multiple national and international committees and is widely recognized for his contribution to clinical research and advancing pharmacy training. Now, please join me and welcome Dr. Abdulrazak Al-Jazairi, and the stage is yours.
Thank you very much, Dr. Ziad. It's really given me a great pleasure to welcome you all to this very interesting session from an outstanding and a very well-known speaker for us, Dr. Majd Al-Jaraisi. Dr. Majd Al-Jaraisi, really, he doesn't need an introduction. He doesn't need a biography to be read. He's somebody that we enjoyed a journey together for more than 3 decades. Through all these years, he's been contributing not only on his institution, but really on a national level. I had the pleasure to live in a crossroad with him as a pharmacist, as a clinical pharmacist, as a researcher, as a leader, of course. And it's just really, if we're going to talk about experience of Dr. Majd, it's going to take us a long of time. And if we're going to talk about the challenges that he overcome over years in his main institution, which is the National Guard, also is going to take lots of time. But Dr. Majd Al-Jaraisi, he's a very well-known scholar, of a graduate of the State University of Tennessee. He did his master in education, also from University of Tennessee. He did his residency and fellowship in pediatrics, and he established and founded the pediatric clinical pharmacy practice in the National Guards over decades, and he continued to lead the residency program in that field. He held different key positions on a national level, in addition to, of course, to his institution, and he continued his journey with some shift into research more recently recently I mean 15 years ago, to go with research in addition to his clinical practice that he continued to contribute to graduate generations of clinical pharmacists in pediatrics. He served many key positions, either in the Saudi Commission for Health Societies, as a consultant for the Saudi FDA, and many other key national committees and advisory boards. Dr. Al-Jaraisi Recently, he's holding a key position in the newly established Saudi NIH. He's an executive director for research and education. And today he will share with us or shed some light on a very important topic for all of us as pharmacists, which is mainly talking about pharmacy, hospital pharmacy practice research, and how can we develop a benchmark and establish more before the benchmarking, really sharing the experience with regard to pharmacy research and hospital pharmacy practice. It is a very important topic because we know as the institute, as Saudi Arabia is going under a very major transformation, especially when it comes to privatization, improving outcomes. We need to develop a real hospital pharmacy practice that we can benchmark our outcomes internally and externally to justify our existence, to justify to getting paid as a professional or healthcare providers. It is an area that we all need to develop together. It's an area that needs a real strategy on a national level, and there is no better person to discuss and address this than Dr. Majid Al-Jraisi. Please welcome Dr. Majid Al-Jraisi to the stage.
Assalamu alaikum wa rahmatullahi wa barakatuh. Masakum Allah khair. Thank you very much, Dr. Abdul Razzaq, for the nice introduction. And what he mentioned, Dr. Abdul Razzaq, about me, just times this by 3 for his career and his involvement and his contribution to the profession as well as to the field of research and pharmacy. First of all, I'd like to thank the organizing committee for giving me this opportunity to speak in this very important conference about a very important, hot topic for us as a pharmacist. It's really the first time, in fact, to address this issue, which is really important. And we will discuss the importance of this topic during this talk. And you will see why we have addressed this topic in a way to be emphasized more and to take action. So without further ado, I will just deep dive on my talk about the need for sharing experiences and establishing a benchmark for hospital pharmacy practice in our country. So if we ask about the need for establishing and sharing experiences, why we need to establish a benchmark for hospital pharmacy practice, obviously there are many reasons. Variability in practice will lead to variability in outcomes. So without having a standardized practice, then we will be challenged to control the outcomes or to be able at least to predict the outcomes. So if we move towards consistency in practice, then the end of this is going to be reflected and impacted on the safety and value as well. So bottom line is linking benchmark to the best pharmacy practice is the way to go in order to, in fact, not only improving the medication safety, patient safety, improve the quality of care, as well as improve our profession and create more research leaders in the profession. So why hospital pharmacy benchmarking matters? First of all, let me just explain that in more details about the direct impact of hospital pharmacy on patient safety. I think we all know that medication errors is our responsibility as a first healthcare provider, and we should be the leader to minimize and take the responsibility upon our shoulder to minimize the medication errors in the healthcare system. Stewardship, I think we are also one of the leaders in stewardship programs in all institutions, in all pharmacy settings there. So this is part from the pharmacy practice. Definitely, as I mentioned about the clinical outcomes, improving the clinical outcomes is linking to the hospital pharmacy, as well as healthcare cost and efficiency. We are talking about increasing healthcare costs in the country. We are talking about strategy to minimize the healthcare cost. It is going to be through standardize of hospital pharmacy practice. It's going to be through a benchmark of the best practices between among pharmacy practitioners. In addition, with this increase in the complexity of patient care and therapies that and novel therapies that we are having, from biologics, from cell and gene therapy, from new novel medications, I think we have to keep this in mind, and we have to leverage our practice, our experiences, our aim to meet the objectives of or the need for this innovative therapy, and to go more deep in the complexity. It's not anymore a simple pharmacokinetic analysis and pharmacokinetic equations that we do to adjust medications. It's not only that. It's more than this, and we have to keep this in mind and be a leader for this novel therapies and change. So benchmarking is no longer optional. Why? Because it is essential for the value-based care. What is value-based care? It is the pillars. It is the essential element of the healthcare transformation in our country. So we have to be, again, mastering the value-based care, and we have to be promoting this practice. So what are the current challenges that we are facing in our pharmacy practice? First, I think this is very, very obvious: fragmentation of pharmacy practice across all sectors and regions. And there are many reasons. Of course, this fragmentation is getting less and less from year to year. And there are so many reasons for that. Second challenge, which I think a huge and big challenge, and we have to address this in all our plans, strategies, is limited national data on safety indicators, clinical effectiveness, disease and drug registries. So with the absence of these data, we cannot develop our strategy. We cannot develop a plan. We cannot even take any further step without having a robust data in order to guide us to plan our pharmacy practice, or at least take the pharmacy practice into another different level. Another challenge, which is lack of Saudi-specific evidence to guide policy and of standards. I think we all agree that the world evidence-based medicine is the world evidence and the availability of evidence in our practice is lacking, and no one is leading that except for a few probably personal efforts, unfortunately. So again, lacking of these data at a national level is contributing to a major challenge in the country. Yet, best practices exist. We don't ignore that. However, are not systematically observed or noted at a national level. So if we want to take this further from a local excellence to national learning at least, we have to consider the following points. There are many hospitals practicing a very strong and having a strong innovation. However, experiences remain siloed. So without sharing their experiences, without sharing the practices, without sharing the challenges then no one that can fix this problem. No structured national comparison. And we are seeing this. Some of our tertiary care centers have a very advanced, high level, even competing to the best hospitals in the Western region. Other hospitals or other maybe institutions have a lower limit of standards, unfortunately. So we need to close the gap between these hospitals. No shared learning loop. Again, we have to take a lead in sharing experiences between the practitioners, pharmacy practitioners, as well as between hospitals. So the key questions now we have is, how do we transform local success into a national standard? The answer is through benchmarking or doing research to benchmark the and having a system function. So reframe benchmarking as health system research, outcomes and safety research, comparative effectiveness studies, implementation science. So we have to keep this in mind. We have to develop a strategy on each element of these benchmark in order to have a robust benchmarking in our country. So benchmarking is not just a simple comparison between institutions or even between our country and other countries. It is more than this. It is a generation of evidence in order to have a real benchmark and a real game change. So here we need to talk about the role of Saudi NIH in this, to fill this gap. So Saudi NIH was established by the royal decree to advance the kingdom's translation research and clinical trials ecosystem to improve national health outcomes through the following elements: national health research leadership, standardization of data and methodology, multi-center and cross-sector studies, evidence to policy translation, capacity building, and workforce development. I am sure most of you might think this is so difficult to accomplish. It is not easy to go over these initiatives and fix them all. Of course, the answer is yes, we cannot do it all at once. However, we have to take the first step. Let's think about Saudi NIH as an enabler. What can Saudi NIH do in this gap? So under Saudi NIH, hospital pharmacy benchmark can be, first, a national research target. So we can have a national target for benchmarking of hospital pharmacy practice. It can be done through a research grant from the Saudi NIH. Enabled by shared data platforms. Again, it is very difficult and probably it is not easy to have a unified national database across all the country, except if it's taken by a national leader like Saudi NIH. So we built the national database platform and we try to collect data from different institutions. Translated into national evidence and policy advice. Of course, after creating this national data, we have to transfer it into national policy. Neutral, trusted, and scientifically rigorous. It has to be through a scientific, rigorous platform. Otherwise, it might probably fall down after a short period of time. So Saudi NIH enables pharmacy researchers while hospital pharmacy deliver the service. So this is the bottom line. So we can create the capacity of pharmacy research while improving the quality of pharmacy services that we deliver. And it has to be linked between the two elements. So the proposed national initiative that I came up with through standardized national indicators, secure national data sharing, annual benchmarking and outcomes report, research and safety, efficiency and innovation, training programs for pharmacy leaders in research and quality. Especially the last element is very essential and one of the, again, pillars of the Saudi NIH to build the capacity. Human capacity, building human capacity of researchers, not only at a pharmacy level, but also at a physician, nurses, dentists, all healthcare providers level. It is the responsibility and the mandate of Saudi NIH. So this is something that is very important. And by the way, we can start with this step. We can develop, and maybe a few weeks ago, I was talking to one of the leaders, in fact, to develop a program to enhance the pharmacy leaders in research and become a PI leading research grants and applying for research grants. If I ask the audience, how many of you have submitted or think to apply for a research grant that was announced by Saudi NIH? Hands up. Expected, Dr. Abdul Razak. Unfortunately, so I think we have not a long way to go, but we have homework to do. So by doing this, it's going to be aligned with our vision of health transformation. So this initiative is going to support value-based healthcare, as I mentioned, patient safety and quality, digital health and data-driven decisions, workforce localization and leadership, innovation, clinical trials, and biotech readiness. These are all elements is going to support the vision of 2030 and also supporting the health transformation. I know each element needs to talk about it, but unfortunately with the limited time, I cannot, in fact, explain it more because I have another part that I need to shed light on and be aware of what we are moving towards in the Saudi NIH. So as you all know, the announcement of the national aspiration and priorities for the research development innovation for the next 2 decades was announced by His Royal Highness Prince Mohammed bin Salman. It was through these pillars. Please keep these pillars in your mind and see what can you contribute as a pharmacist in order to fill this gap. Becoming a global leader in research, development, and innovation. And take it from the pharmacy perspective. Annual investment equivalent to 2.5% of GDP in 2040. So a huge grants is coming. Add 60 billion Saudi riyals to the economy of 2040. What does that mean? It means there is a huge support from the government to the research. So be prepared for that. Creating high-value jobs in science and technology. Again, you have to equip yourself with research and skills in order to have probably high market value, I would say, because adding element of research to your career, I think, is going to have a huge market value in your profession. See, the national alignment, I think we have to be all aware of this, delivers on one of the 4 national RDI priorities, which is health and wellness. What does that mean, health and wellness? We have to increase the life expectancy by 5 years, focus on rare diseases, therapies, and development by 2035. So we have to be ready for that. Digital therapeutics for 40% of population. And please go and read about digital therapeutics. We have a huge role in digital therapeutics, by the way, as a pharmacist. 50% reduction in non-communicable diseases burden by 2035. 50% drop in infectious disease incidence in KSA by 2035. Keep this in mind again. This is very important, and we have a major role as a pharmacist to contribute at a national level in these major initiatives. I think for the sake of time, I need to skip this. So just to summarize and to tell you more about the role of the Saudi NIH and the strategic focus areas, as I mentioned, the Saudi NIH is enabling clinical trials, so anything related to building capacity of clinical trials or research grants for clinical trials, it's at the Saudi NIH. Funding translational research. Translational research, by the way, it's a major area for us as a pharmacist to contribute in. You can apply a grant for translational research. We have huge impact from pharmacists to build capacity on translational research. Transforming health research outcomes into health and economic impact. Again, this is fall under our rules and responsibilities. Enhancing the research environment by the Saudi NIH, again, by building the research capacity. So these are the four strategic goals that we are embarking on at the Saudi NIH. While doing this, one of the mandates is to develop health research priorities. And among the audience, Dr. Mohammed bin Dakhil and Jude Sger working hardly on developing the research health priorities. If you are not aware yet about the health research priorities, please go and read it, because our focus of grants is going to be focused on the main health research priorities. The top 5 health research priorities: cardiovascular diseases. So our colleagues from critical care, cardiovascular disease will be happy, and Dr. Abdulrazak is one of them. Second is cancer. There are so many, I think, friends, colleagues in oncology, clinical pharmacy. You have major role in this. A third one is the endocrine and metabolic. This is related to internal medicine, rare diseases, infectious diseases. See, these are the top 5. And the rest is again, we have 17 research priority areas that we are going to support in the next 5 years. These are just a mechanism of what we are supporting in the Saudi NIH: translation from bench to bed, translation to market, translation to practice, and empowering translational capabilities. This is a recent article published. Maybe some of you have already seen that, but this is very important. Clinical pharmacist as principal investigator. So the American College of Clinical Pharmacy has published a new data about the involvement of pharmacists as principal investigators in research. And they are like measuring and seeing the trends of how many grants, how many federal grants, because this is done in the US. How many federal grants from 2010 up to 2024 have the pharmacists contributed as the principal investigators? The curve is growing up, unfortunately, but it is very, very slow. So it is released in October. The bottom line and the call of action, by the way, of this paper, and I would urge everybody to go and read this paper, please. The call of action in this paper is to empower, to enhance pharmacy research skills and training in order to inject more researchers in pharmacy as a principal investigators, not as a co-investigators or sub-investigators, but as a principal investigators to submit research grants. So my takeaway and call to action: sharing experiences requires structure. So again, we have to take this burden on our shoulder and responsibility to share our experiences. Without sharing our experiences, we are remaining in the same phase. So we shouldn't be working in a silo, but working as a group, as a team. Benchmarking requires data, research, and trust. Keep this in mind. Without creating enough national data, we are not going to be transformed into a national or international benchmark. Saudi NIH facilitates the national platform to transfer practice into evidence. I think from our end in the Saudi NIH, we can support this initiative if really we find a good support from all pharmacists and practitioners for this initiative. Together we can reduce variation, improve safety, strengthen outcomes, build a unified national standards for hospital pharmacy practice to serve our community and our patient safely. And thank you very much.
Thank you, Dr. Majid. This is a very nice, inspiring, and very comprehensive lecture. I'm going to start with one question, then I'm going to open the discussion for the audience. To set the stage for where I'm coming from, when I was a director of pharmacy at King Faisal, we asked for pharmacist adjustment in their salaries, in their package. Particularly started with the clinical pharmacists. And when we talked with our professional HR, we talked to them about the benchmark in the States, why these guys needed to be highly paid because of their contribution to patient outcomes, safety, cost saving, and so on and so forth. And he said, that sounds very good. Show me your data. I'm not going to adapt whatever available in the States to Saudi Arabia. I need a homegrown data or home-generated data to adjust for this. And we do know that we're going through a transformation by 2030. Part of it is privatization. We need to be justifying our salaries, expanding our capacity, and so on and so forth. Which goes back to your main point. We need to generate data, to standardize KPIs, to know where are we going, and to justify our existence and our paid salary. If you take a look into the presence of clinical pharmacists as a job in private sector as compared to governmental sector, there is a big variation, big deviation, and the number is really higher in the governmental sectors compared to private. So it's still in the private, they don't see the value unless we have data to show that value. In your opinion, now, and I know you did lots of work, I did lots of work, many leaders did lots of work on an institutional level to come up with data for benchmarking for our contribution or KPIs on patient outcomes, safety, cost saving, or money generation. Who will be the stakeholders in our ecosystem to adapt these national KPIs and strategies in order to unify? So you talked about safety. I remember we did lots of communication with the patient safety, national patient safety. Is it a society? Who should set this KPIs to justify adaptation by different stakeholders within our healthcare system, in your opinion, and to give some consensus where this data can be generated and trusted by decision makers like HRs or Ministry of Labor?
Thank you very much, Dr. Abdurazak, for this important question. I know that, and I have addressed this briefly in my talk, is the having and hosting and controlling the national data is a bit challenge, because controlling the access and the ownership of data is an issue. So not to reinvent the wheel, we have, many options. Definitely, I think we all agree, this data has to be hosted and I would say maintained by a national entity, whether Saudi NIH or whether the Saudi Health Council, but has to be hosted and maintained by a national entity. This is one. I think the NIH is the best probably place to host the data and to, in fact, have the custodian of the data. This is one. Second, which is really important. I think having support from the pharmacy societies, I'm talking about all the societies together, is very important, very essential in order to support this initiative. Because if at the Saudi NIH can provide the support, can provide the grants, can provide all the logistics of the data, from the other side, somebody has to push in the direction of managing, or not managing, but creating this data. It has to be at a national level. These initiatives, it has to be with the same momentum among all pharmacy practitioners in the same way. So it has to be, again, a push from the societies as well as from the pharmacists, and supported by the Saudi NIH.
So yeah, I agree. You're saying it has to be a multitask, multi-stakeholder standardization of data that needed to be generated, to be adapted, and to be endorsed by these entities. Any questions from the audience? And how do you see the use of AI in hospital pharmacy practice research, either from writing protocols to data analysis, writing manuscripts? How do you see the hospital practitioners using it, and how do you see the other side of journals to adapt and accept this kind of manuscripts, or even for Saudi NIH, these protocols written through AI? What can you guide our new generation regarding the optimal use of AI in writing protocols?
Yeah, I think using AI in pharmacy profession is like any other profession. It's not, different from others. But how can we utilize the AI to probably help us and promote this initiative? This is very important. We have to be careful about using AI. I think all of us know that there are pros and cons of using AI nowadays, but utilizing it, using it in a very smart way to support our plan, our strategy is really important. The other thing is shorten the time for creating a plan or for collecting data. I think this is something that we have to utilize and maximize the utilization of AI in order to support this initiative. But using AI in writing research protocol, or I think it's already been used, utilized, and there are so many courses being delivered to teach and to train researchers on how to utilize the AI in writing research proposals or writing protocol. However, we have to be careful. Generating research proposals or protocol development, just copy and paste, this is a huge violation. And we have rejected so many applications, by the way, when applied to our grants, because it was generated completely 100% by AI, unfortunately. So we have to be careful using this technology and this methodology to help you, not to work on your behalf.
Thank you. We can take questions from audience. Anybody have a burning question? Okay, so we take the last question then. As they say, first comes first. If we have for hospital pharmacy practice research, where do you see the top three needed researchers or research domains that needed to be put in priority, so we guide our current practitioners and new generations to focus on from a hospital pharmacy practice research? What's the top three in your opinion?
Excellent question, Dr. Abdulrazak. I think we have to be aligned with our national priorities. So where are the national priorities, health research priorities? We have to align with that. We cannot identify an area that is not probably from the top list of our research priorities. In order to get support from the national leaders, health leaders, and also to contribute to our community, to our country, of generating new data to decrease the healthcare cost, increase and improve the quality, and decrease the burden of diseases. So again, as I mentioned, health research priorities already established. So we have to work on how, from a pharmacy perspective, how can we help and generate, or let's put it this way, fill the gap in our database, a national database, to help others to fill or to at least take it to a next step. One of the, by the way, things that is very unfortunate, very striking and painful, cardiovascular disease is the top priority, right? What is the outcome of publications in the cardiovascular disease generated and creating from our country? Represent only 5%, although we see a huge trend of publications every year we are number one, by the way, among the Arab countries in publications, and from the probably top 20 from the regions. Yet the major gap of cardiovascular disease is only 5%. So we have huge and contribute to this filling the gap of cardiovascular disease. We have a major role to do this. So again, align with the national priorities, I think, is the answer to your question.
Thank you very much. Very well said, Dr. Majid. As usual, very enlightening, inspiring, very directive, very structured presentation. Thank you for your time. Thanks for our audience for listening, and we come to the end of this lecture. Thank you.
Shukran.
Before we conclude, we would like to present a token of appreciation to our speakers and session chair for their valuable contribution to today's session. We kindly invite Dr. Mohammed Al-Isi to join us on the stage to present a certificate of appreciation. First, we would like to invite Dr. Professor Majid Al-Jaraisi, and thank you, Professor Majid. Thank you, Professor Majid, for your insightful contribution, research expertise, and for sharing experience that continue to advance pharmacy practice research and inform evidence-based benchmark. Finally, we would like to invite our session chair, Dr. Abdulrazak Al-Jazari. Thank you, Dr. Abdulrazak, for your leadership, insightful guidance, and for moderating this session with clarity, depth, and expertise. Ladies and gentlemen, this concluding session 8. On behalf of the organizing committee, thank you for your attention and engagement. We hope today's sessions inspire continued growth in pharmacy practice research and evidence-based care. My name is Ziad Saeed Al-Ahmadi, and it was an honor to serve as your introducer. And now, we will have a camera gift segment. And please remain seated. Thank you. for your presence and engagement, and we wish you a productive continuation of day 2. Thank you.
Good afternoon, everyone. I am Abdulaziz Al Asiri, a PharmD graduate from King Khalid University, and I would like to welcome you all to this session titled Unique Opportunities for Pharmacists in Saudi Arabia. This session highlights the expanding roles of pharmacists across diverse healthcare settings in the kingdom, showcasing their impact in public health, specialized care, rural practice, and evidence-based clinical decision-making. Our session today will include 3 lectures and dedicated Q&A segments. Our speakers for this session are Dr. Fuad Bahamdan and Dr. Abdurrahman Khalaf al-Shammiri. It is my pleasure to introduce our session moderator, Dr. Mani Faris al-Najib. Dr. Mani is a pediatrics and neonatal clinical pharmacist consultant and residency program director at the Ministry of Health, King Khalid Hospital in Najran. He completed his PharmD at King Faisal University, BGY1 training at Johns Hopkins Aramco Healthcare, and BGY2 in pediatrics at National Guard Hospital, Riyadh. He is American board certified in pharmacotherapy, nutrition support, and pediatrics, and holds a master's degree in healthcare management. Welcome, Dr. Mani. We are delighted to have you with us here. Without further ado, I will hand this session to Dr. Mani to begin. Thank you all, and I hope you enjoy this session.
Assalamu alaikum wa rahmatullahi. Thank you so much, Abdulaziz, for your introduction. So we start our session. We have our clinical pharmacist, Dr. Fuad Bahamdeen. Dr. Fuad is consultant pharmacist specialized in pharmacy administration. He got his PharmD degree from Ohio at 2018. Then he joined with he completed his BGY2 residency also in pharmacy administration. Now Dr. Bahamdeen currently serves as the head of a clinical and critical care unit at King Abdullah Medical City as the Deputy Director of Pharmaceutical Care Services. So welcome, Dr. Fuad Bahamdeen.
Thank you, Dr. Mani, for this wonderful introduction. It's an honor to be here, and thank you all for taking the time to listen to me after a wonderful 2 days, or we're in the second day. I don't know if the slides are on. Okay, let me take a minute since they're preparing the slides to thank all the committees and everybody that worked to make this wonderful event happen. Thank the committee, organizing committee, scientific committee, and all the volunteers. Can I begin? Okay. طيب. I'm going to start by kind of trying to remember what I had in the slides. Overall, in the next 20 and so minutes, we'll talk about the role of pharmacy in mass gathering, so trying to understand what opportunities do we have. Talk a little bit about our experience at Mecca Health Cluster, and lastly, identify some future opportunities and future directions for pharmacy and mass gathering with a focus on Hajj. Okay, here we go. Awesome. So, moving on, as we all know, Vision 2030 kind of highlight the needs for, or aim to be a hub for mass gathering. As you can see, future-wise, we have large events like Expo, World Cup, planned to be in Saudi, and that can open up the doors for us as a pharmacist to identify what rules do we have in these mass gatherings. There's not only aim for an events, it's also a systems transformations, where as you can see both healthcare, tourism are being transferred, and pilgrims and kind of accepting visitors had been an ongoing. So we're shifting from a seasonal kind of healthcare or care into a continuous year-long kind of hosting of those religious gathering and being able to have a seasonal response. And again, we're seeing more than 100 million visitors annually. Last year we had 1.6 million documented pilgrims for this kind of year's Hajj season. So again, there is a continuous healthcare readiness needs in Saudi. So let's take a little bit of a deep and kind of zoom in to identify who are we talking about when we talk about mass gathering and with a focus on Hajj and pilgrims. So as you can see here in the slides, we have a majority of pilgrims coming from outside Saudi as the majority or take the majority of the percentage. And again, last year we had more than 1.6 million. So if we also look at these numbers in a different kind of view, we see that we host multinational pilgrims, as you can see with the different nationalities, and this data came from 2022. So probably a question you're wondering, so how much healthcare takes from pilgrims and Hajj preparations in terms of labor force? As you can see, it's the third, and we're looking at around more than 30 or around 30,000 forces or labor forces designated only for healthcare services. And out of these services, we see emergency response being the highest, followed by hospitalizations. And again, what medical facilities and what teams do we see kind of highlighting, or the need for it is being highlighted? We see operation unit teams being the highest with more than or around 500 teams. So the question that comes to our mind is, what is really our rule? And then I kind of like this picture, it highlights our most significant rule, which is we're basically a safety net as a pharmacist. So that rules applies to Hajj, where we see pharmacists being the safety net, being the main rule and responsibility. But generally, let's go over some other responsibilities us as a pharmacist can take on. Medication therapy management, antimicrobial stewardship, and I'm not just going to say antimicrobial, it's stewardship in general. Also emergency responses. We're looking at crash car preparations, emergency cases, kind of supporting. In supply chain management, we've seen a lot of advancement. Every season we see it throughout the Hajj, where we see new initiatives around supply chain and how we can deliver those medications in a short time with using kind of unique and innovative routes. Health educations and promotion, and mainly for patients. And we also see training and educations for healthcare providers as well. And also medication reconciliations. As I've shown you, a lot of these pilgrims are coming from different countries. So medication reconciliations and ensuring they have their chronic medications and needed medications continue is an essential rule. Lastly, documentations and reporting will also play a role in that as medication safety guards and making sure medication errors and other adverse drug reporting being properly documented and reported. And again, these two pictures shows you one of the sessions that we had in one of the hospitals in Hajj, where we provided educations for healthcare providers, and also preparing crash cards for those events. So what are the challenges? I'm just gonna list them all here for you. With those responsibility obviously comes in some challenges that makes these tasks sometimes hard to accomplish, or we can take a focus on these challenges to also address them and find gaps as a pharmacist. Definitely crowd control and weather conditions can plays a big role in those challenges. Healthcare risk, working in a hospital, working in a crowded places can also increase those health risks. Language barriers, as I've shown you, and we talked about it a little bit. Logistic issues and challenges, again, navigating those mass gathering and making sure patients are getting their medications in a very rapid, timely manner. Regulatory compliance, we'll talk about ensuring that each of these hospitals are meeting the standards for Sabahi, for example, and then crisis management in terms of coming with a solution and being able to be fully prepared prior to having any incidents of kind of crisis and emergency response. So now that we in general just highlighted a couple of rules, and we talked about the general challenges that we face or possibly pharmacists can face in mass gathering with a focus on Al-Hajj. Let's talk about our experience at Mecca Health Cluster. So one thing we have to kind of discuss is that we have two type of hospitals. Under the Mecca Health Cluster, there's around 15 hospitals that are listed as, we could call it, non-seasonal hospitals. Some of those hospitals are trauma centers. We have 2 tertiary hospitals. And then we have something called seasonal hospitals. So these seasonal hospitals are only open during Hajj. So fully prepared from zero, kind of just the building obviously is there, but everything around preparations of operations for the hospitals are completely done in a very short time during Hajj seasons. And for, just to give you a little bit of kind of sense on how many hospitals are there, where last year we had 7 hospitals, and we'll talk about it in a few minutes, but we're starting to see the adaptations or the participations of the private sectors leading those hospitals. And also beside those 7 hospitals that are for Hajj, we also have around 94 centers, healthcare centers around both Mina and Arafat regions. We also have something called field hospitals, so prepared by the armed forces, but run by healthcare or Mecca Health clusters as well. And usually those numbers we're looking at 3 to 4s, it depends on the seasons, as for those field hospitals. And usually they're located in the area where we have the most crowds for Hajj. Okay, so now that we talked about the general kind of background, we provided some information around the hospital itself. It's important also to highlight the rules of the committee that are in charge of Al-Hajj, or ensuring that at least the pharmacy part of it is going smoothly. The Ministry of Health, run or led by Dr. Mohammed Shinawi, is one of the committees in charge of ensuring the Hajj operations and supervision going smoothly. And then we have the Mecca Health Cluster Executive Committee as well. And lastly, we have supporting services outcome, both the Mecca Healthcare run by Dr. Fahad Al-Hafthi and supporting services run by Dr. Nizar Khayyat. So these 3 committees they have inlined their job and responsibility. Some of it even overlap to ensure that we don't have any gaps in terms of preparations, oversights, and operation. And we'll talk about it in a second. So what do these committees do? As you can see here, again, for the MOH committee, we see a lot of preparations ahead of Al-Hajj seasons, where they're making sure accreditations, review, coordination between stakeholders, supporting with resources. And then we have the executive committee for Mecca Healthcare, more on hands-on operational responsibilities in terms of implementations, monitoring, evaluating, addressing any challenges or issues that we can encounter. And lastly, the supervision. Those are the head and shoulder soldiers that kind of follow up, monitor, do the auditing to ensure we have very zero mistakes and gaps during the season. So probably one of you wondering, when do we start working on Hajj seasons, and how was the operations kind of timeline? So to give you a simple answer, it's an ongoing process. We start with the pre-Hajj tasks, during Hajj tasks, and then post-Hajj tasks. And these tasks, again, as you can see, they're ongoing throughout the year. Just to give you a little bit of hints of some of the tasks or the main functions that we do prior to the Hajj seasons, making sure that we have a full alignment with the stakeholders is one of the most important tasks and responsibility that we have to ensure prior to the Hajj season. So making sure the MOH, Ministry of Health, NIPCO, in charge of the supply chain and medication delivery, making sure the formulary is set up, making sure that we've selected and navigated kind of the medication shortage, access to some of these important medications have been resolved. We kind of align the supply chain kind of gaps in the MOH manpower selection, which we'll talk about it in a second, and infrastructure and so on. And then again, we talked about formulary challenges. And lastly, compliance with the best practices. This is something has been emphasized more recently with Sabahi. Accreditations for all these hospitals became mandatory. So we're working on ahead of the seasons to ensure that once we have those operations set up, we have everything in order for those compliance and auditory visits. So let's move on into, or let me give you a little bit of examples on some of these challenges that we have faced. So assessing human capital needs, as you can see here on the left side, we have the MENA centers, all health centers, and we have the number of RX or number of prescriptions that we have collected or observed in each of hospitals. And then we have the number of specific healthcare centers shown on the right side as well. So what these three images kind of provide us with some type of guidance into the manpower management. So where do we need to kind of put more emphasis in terms of manpower preparations, in terms of pharmacists, technician, and clinical pharmacist. So a lot of kind of auditing and data review, we do it prior to the seasons to ensure that in case we have some type of surge in those centers or surge in number of prescriptions in a certain area or locations, we have accommodated for that and we have enough manpower for pharmacists to run sufficiently. Supply chain coordinations, as I mentioned, we always kind of monitor what are the most prescribed medications in Hajj seasons. We monitor the quantity of those medications to ensure that we have sufficient on hands. And again, navigating those shortages is always a challenge for us as a pharmacist in general, especially for Hajj, since we have a short time sometimes to run around all those sudden shortages. So what tasks do we have during the Hajj seasons? So monitoring those supply delivery. So once we set up the formulary, once we set up the supply chain management, we need to make sure that those medications are delivered fully and everything we have on paper are reflected on stock for pharmacy across the Hajj region. Visit fields, something we also do to make sure that provide kind of full support, making sure all the operation process is running smoothly, and we also monitor any gaps and try to resolve it immediately. And then address any challenges that, as I mentioned, ensuring staff preparedness, so ensuring that everybody got enough training, that every pharmacy has some type of an expert in each area, for example, inpatient services, ICU, clinical pharmacy, and so on. And then they have access to training protocols and guidelines. It's something also we ensure that not only done, but also being implemented, which I will talk about the standardizations challenge in a second. Ensuring safety and policy adherence. Again, we have a lot of policies that are being changed every year around protocols, guidelines, and so on. And even expand in pharmacy privileges is something we worked on this year. So we always try to ensure that those changes are being implemented as well. And then most importantly, I think this is one of the main tasks we ensure to fully accomplish during Hajj is to ensure that we have a clear communication channels. Being able to respond to emergency and have a kind of crisis management requires immediate response. So we ensure that all pharmacists, leaders, and staff in all healthcare centers, those 94, and even in those large hospitals have direct access to us in case they required any kind of assistance. And we have a clear communication with assigned person to address those issues, for example, like drug shortage or sudden need for non-formulary medications, or if we have some type of issues with delivering medications. So I'm just gonna also give you a little bit of examples of things we have done as well. One of the years we've had issues with redistribution of crash card, where we had limited healthcare centers with a limited access to crash card, so we had to immediately redistribute in a very short time. And then we one time also had an incidence of one of the field hospitals did not have the perfect environment for medication storage, so we had to delay the delivery of medications. So what are the tasks that we do post Al-Hajj season addressing those challenges? Definitely we target every pharmacist that actually had hands-on training or had, hands-on participations on those Hajj to make sure that we collect all the feedback that we have. So we have a specific survey for healthcare workers, focus on pharmacists, to collect any issues, challenges, to address them in the next year. And also hospital leaders, we do a final visits to address any challenges, kind of make sure that their voice been heard. Documentations is part of the process, so making sure all these reports are being raised or those voices are being delivered to the higher management. And we have some type of comprehensive report, highlight the achievement, the challenges, and what resources we need for next year. And then again, the preparations where it's a continuous process, as I mentioned. So it's preparations start right after the end of each season. Okay, let me give you a couple other examples of challenges we had. Clinical pharmacy has been something that recently were introduced into the Hajj, with clinical pharmacy actually being part of the pharmacy services. So we've tried to look at the needs for, or where are the hospitals with the most need for clinical pharmacists. As you can see here, we have distributions of multiple hospitals with different ICU admission. So kind of that shifted the needs for more ICU specialized in those hospitals. And then on the right side shows you the number of clinical interventions that we recorded from our both pharmacists and clinical pharmacists. And this is also highlight the point that I just mentioned. Again, with different specialty, as you can see, cardiology, critical care, infectious disease, and internal medicine. Again, the main goal, as we have seen early on, we have a huge need for emergency and critical care. This is highlighted by the recruitment numbers. So this is also an example that we've dealt with medication errors. We addressed it, and we had corrective actions to kind of make sure that those hospitals had first high number of reported medication errors, and then they have addressed those challenges, and if it's something that needs to be reported and resources needed, we've raised that as well. So this is also an example of documentations and data review that I mentioned to you early on. So this is a report that we have to do annually in collaborations with the Ministry of Health, the pharmaceutical team there as well, listing the negatives accomplishments, and what are the resources needed. And this is just a snapshot of some of the data that we look at every year to assess, again, workflow, assess the manpower need, resources allocations, as we look at the number of prescriptions, number of patient admitted, ICU admitted patients, and then again, as I mentioned a second ago, number of clinical pharmacists, medication error, and so on. So now that we talked about our experience and we highlighted the general overview of the Al-Hajj and mass gathering in Saudi, some of you is probably wondering, where are we going in terms of future? What can we kind of find, or where can I contribute as a pharmacist in the future for us as an opportunity? So one of the things that I'm going to highlight, and I'm going to briefly go over it because my session is right after Prof. Geraisi and Dr. Abdulrazak, so it's unfair to go out right after them and talk about research. But in general, what I wanted to highlight is that we have a lot of gaps in terms of research. This is one of the research done by Dr. Ihop, just kind of gives us an insight about clinical pharmacy services and mass gathering. They've also done, Dr. Khalid Sulaiman also have done research around ICU patients, so kind of describing the clinical pharmacy intervention in the ICU. And lastly, the last paper that came out last year, the AI framework for mass gathering, which was an excellent also paper done by Dr. Khalid Sulaiman. So these three papers that I was able to find around Hajj related to pharmacy or clinical pharmacy. So this literally highlight the gaps that probably Dr. Geraisi or Dr. Geraisi kind of mentioned some of those strategies that we can overcome. But definitely I want to highlight two things. One, we have a huge gap. Two, we definitely have to shift our focus from more retrospective kind of research, descriptive research, into more proactive. So looking at more randomized clinical trials done in Hajj. Doing more kind of practical research. There is a huge opportunity, and definitely there is even a bigger gap. So not only in research, we also see a gap in training. Some of the things that we definitely can lead on, not only in Saudi, but we can lead it in the region and probably globally, is that we could be a hub for training residency and training clinical pharmacists in terms of mass gathering. And what can we as a pharmacist do, and kind of gives them more hands-on training. And then one thing we have also worked on this year is creating a job description, kind of defining those rules for pharmacists in mass gathering and also clinical pharmacy. So we're still kind of in the phase of structuring those services. So definitely there is more and more needs and opportunities around those as we are building those rules, not again for Saudi only, but globally. And lastly, definitely innovation, AI, and healthcare solutions is a huge opportunity for us as a pharmacist. And then lastly, I'm just gonna briefly highlight some of the areas that we can innovate. If probably some of you are wondering, what solution could I come up with? Or what area do I need to focus on? So healthcare capacity, we know that healthcare in general, capacity is a challenge that we're facing. Logistics, probably some of you have seen the drones delivery of medications that was established last year through NIPCO. So this is another innovative way to kind of go around the logistic part or difficulty of logistic parts. And then multilingual support. We have a huge gap around dealing with those pilgrims with limited kind of language or health literacy. And then emergency response, definitely a huge role for us to strengthen that, improve the healthcare, improve our rapid response to those needs. Collaboration, partnership. We're trying to do that, but there's definitely ways that we can improve. As I've shown you, there is a lot of sectors that are involved in Hajj, but that kind of put emphasis on the collaborative part. And then technology integrations, and lastly, continuously evaluations and making sure that we have proper monitoring and inventing ways to kind of transfer those numbers into action items. I'm also going to give you one practical examples of it's not necessarily innovative, but it's a solution that we came up with that solved a major problem that we had, which is standardizations. So as you can imagine, in Hajj seasons, we have employees from all over the kingdom coming in with a different background, different protocols, different practices, coming into one location. So the biggest challenge we face is how can we standardize that care to best making sure that all patients are receiving the best care possible. So one way the Ministry of Health have done a great job in is creating an orientation, so standardized orientation for all staff, making that a mandatory for acceptance into a Hajj task or into Hajj or being part of the Hajj. And then we also came up with something called Hajj Manual for Pharmaceutical Care, where we put everything related to pharmacy into one PDF file. So in terms of policies, protocols, contact informations, locations for those healthcare facilities and hospitals, and all the resources like standardized crush card items, formulary, non-formulary forms. So we put everything in one single manual that we ensure that it's distributed to every pharmacist that are participating in Al-Hajj. So something we're editing even annually as we're updating those policies. So these are just small solutions that we try to highlight, or we try to encounter some of the challenges that we faced. This is also an innovative idea that came out of one of the clinical pharmacists. Is again, some of those healthcare workers, nurses, practitioners are coming with their own protocols, which sometimes it might not be updated, or it might be based on their practice in their centers. So we came up with a standardized, or the clinical pharmacist came up with a easy to access barcoded protocols and guidelines. They took those guidelines from the manual and they transferred it into a scannable access protocol for nurses in the critical care and ER to easy access those protocols and making sure they're compliant with it. I'm just going to briefly go over some of the other initiatives. Probably going to highlight two more important initiatives that we, as a pharmacist, came up with. Let me kind of shout out to Dr. Fahad Al-Khuzai, who last year came up with a very innovative, and his team came up with a very innovative AI tools that helps patients easily kind of through just taking one picture. It's called Pharmini. It's an app currently in Apple Store. You can take one picture and it literally tells the patients what is the medication. So if you have a patient that does not know the brand name or generic name of their medications, or they're bringing those medications from a country that does not necessarily have the translations on, you can just take on a picture, and that AI-generated system will help you transfer that into an English language or any language you choose, and make it easy for the pilgrims to access those informations and answer some of those medical informations in a timely manner. We've also, as you can see in the picture, one of the pharmacists also came up with a very creative idea to have a barcoded tag on some of those medications. Those barcodes have videos that explain the patient's their counseling or important counseling point in multiple languages. So you just scan the barcode, select the language that you want the video or instructions to be displayed in, and then we'll have full educations for those patients. So probably some of you are wondering, the main questions is, how can I be part of this? So the answer to that question is, for hospital pharmacy, I'm going to highlight some of the main requirements. You have to have, obviously, a license, pharmacy license. You have to be classified as a pharmacist. You have to be employed. And then there is two ways that you can sign up for Al-Hajj as a pharmacist, hospital pharmacist, or pharmacy technician, through either MOH announced staffing announcement for Hajj, or through internally for Mecca and Jeddah regions, and some of the clusters as well under the MOH umbrella. They have nominations of staff who want to participate in Al-Hajj. In addition to that, you have to make sure that the mandatory requirement like BLS, infectious, and you have done the Hajj orientations as well. and then you will be assigned to either hospital pharmacy or temporary Hajj facilities, as I mentioned. Hospital pharmacy, those are the non-seasonal that I told you about. For clinical pharmacy is a bit different. There is two things that are different. The one thing is that you have to have a license and you have to be senior or consultant clinical pharmacist classified. And then you have to have some type of experience that's preferred. And then it's usually through nominations, either through the Ministry of Health, Mecca Healthcare Clusters, and those are the two responsible bodies for nominations of clinical pharmacy. And some of these clinical pharmacy positions are also announced as well. So we talked about clinical pharmacy. I'm just going to briefly highlight to you some of the additional rules that clinical pharmacists, after they're enrolled with us, they take on, or we mandate it from them. Obviously, beside the general tasks like orientations, making sure they're explaining those protocols, clinical guidelines to the healthcare staff, making sure that these informations are being distributed, participate in sterile compounding preparations for nurses. Also, they have to take on rules during the Hajj season, like making sure that they have access to or participate in multidisciplinary kind of care teams, rounds, and respond to ICU and ER situations. And lastly, post-Hajj, we have a lot of work that usually done around updating those protocols, formulary, making sure that we also require them to work with us to fill in the gaps that I told you about, the research gap, making sure that we're getting more auditing and feedback from them since they've had hands-on practice and experience. So that brings me to the end. One thing that I want to say is that we definitely as a pharmacist have a huge opportunity, as you've probably heard from me multiple times, in mass gathering with either Hajj or later on with these huge events that we'll host in Saudi, inshallah, in the near future. So there is a big responsibility we have to take as a pharmacist in being more proactive in creating those rules, have those rules structured, and definitely participate in taking or achieving and making sure healthcare is playing a big part in the 2030 vision. With that, thank you all. Actually, before I end, I definitely want to shout out special thanks for those who the work that you've seen and everything I presented today is not a single person effort. There's a lot of pharmacists, a lot of leaders, and a lot of teams have worked extensively to ensure that all these things or every season is going smoothly. So definitely I want to take a second to thank them all. And with that, that concludes my presentation. Thank you.
Thank you so much, Dr. Fuad, for your extensive presentation about pharmacist role in mass gathering. Really, we are proud of you. So our next speaker, Dr. Abdurrahman Khalaf al-Shammari. He is a clinical pharmacist. He is director of outpatient pharmacy and the chairman of hospital antimicrobial stewardship program. Dr. Abdurrahman al-Shammari, he is going to present about rural pharmacy practice, overcoming challenge to deliver excellence in patient care. So welcome Dr. Abdurrahman to the stage.
Thank you, Dr. Manaf, for the introduction, and good afternoon, everyone. It's my pleasure to present here today to discuss a topic that is set at the heart of equitable healthcare access, which is rural pharmacy practice. And before I start, I would like to congratulations to Ihop team that they have reached the 7th edition of Success, Innovation, Insights, and valuable recommendation towards the real practice. So I have no conflict of interest related to this presentation. My key objectives that introduce the key aspects of rural healthcare settings and highlight the major challenges in rural pharmacy practice, discuss practical strategies to address these challenges. Finally, I will share a real-world success story. So rural communities make up a large proportion of the world's population, and from the remote villages in Asia and Africa towards farming towns in Europe, North America, and Australia. Yet, despite their diversity, they share one common reality, which is limited access to healthcare systems. So, in these regions, the pharmacist becomes often the most accessible healthcare professional. And today I want to talk with you throughout the global challenges of rural pharmacists face and the strategies that are working and how we can collectively push the frontier of patient care in underserved areas. So let's start with this simple question: why do rural pharmacy practice matters? Because around 45% of the population around the world, they are living in rural communities. So they are share similar patterns, which is limited access to healthcare, higher chronic disease burden, and also fewer pharmacists per capita. When you are looking to this picture, we can see the world map, which is you can see as the gray color darken, the more rural area are located. In Saudi Arabia, around 15% are located in the rural areas. So let's take a look how is the distribution of the pharmacists in Saudi Arabia. In this picture, you can see the number of pharmacists per 100,000 people in the province. And if you can notice that in the northern borders and the north regions, province, and also in the south, they are share same limited pharmacists by serving the population. So there are, what is the pharmaceutical care services that we are providing in the healthcare settings? A lot of functional services that are provided in a patient-centered, outcomes-oriented pharmacy practice that is involved the use of treatment plan to achieve patient-specific outcomes to improve the quality of life, which contains cure of the disease, eliminate or reduce the patient's symptoms, also arrest or slow disease progression. So these are the service category, as you can see: medication management, optimization, clinical pharmacy services, medication safety and pharmacovigilance, patient counseling, etc. And also the advanced antimicrobial stewardship programs and therapeutic drug monitoring that are monitored by clinical pharmacists, which is specialized pharmacist-led clinics, also collaborative practice agreement. So drug information services, education and training and research would be important core of services categories. So what are the challenges? The challenges mainly focus on three components, which is workforce shortages and practice environment, also the social factors. So let's dig deep to those challenges. Workforce shortages and work load. which ins described as insufficient clinical pharmacists involved in the rounds, in the daily rounds. Also, the limited clinical integration of those pharmacists. One important thing is that technology and IT gaps limitation that mainly we see in the rural areas, and that should be, we move into how to solve that gaps. Also the transition of care gaps, or what is called medication reconciliation. So how to overcome these challenges? We can strengthen the force of the clinical pharmacy capacity by expanding clinical pharmacy roles in, and integrate them in the pharmacy residency programs like ICU, internal medicine, ID, etc. And also integrate the pharmacist into multidisciplinary team care plans, and by pushing the pharmacist and motivate the pharmacist to join the multidisciplinary team. And as you can see here, this is the picture from the real life in Rafah, in our hospital, taken last week when we are discussing in the multidisciplinary team round with a GS consultant and in diabetic foot patient infection. So the thing is that when we are pushing the pharmacist participation, the daily rounds, care planning, and empowering the pharmacist with the protocols and authority will improve the patient outcomes eventually. So one of the most important things is that the use of technology smartly. I don't know if there is an rural pharmacist here or not, but they share the same like limitation, which is the technology and IT gaps. There is no automation and limited resources, which is maybe nowadays being expanded by the telepharmacy services, which reduces this limitation. So strengthening medication safety system by providing a no blame culture or no punitive culture system, also the high alert medication protocols, double check system, and also encourage adverse drug reaction or near miss reporting feedback loops. So again, improve transition of care or medication reconciliation. One of the most important things, when the patient came from the home, the pharmacist should review his medication and internal transitions between the wards. Also, after the decision of discharge, the pharmacist should be involved here. Coming to antimicrobial stewardship, which is mainly one of the huge role of a clinical pharmacist. As you know that in many rural regions, the ID physician is absent. So the huge impact is given to the clinical pharmacist to put his insights, his interventions, and set the protocols of treatment of infectious diseases. Coming to align policy leadership and measurement. After this huge role, you have to measure and report the outcomes. If you didn't document and report and measure, you cannot improve, you didn't do anything. So you can measure the report outcomes. These are examples, but not limited to clinical pharmacy intervention, medication error reduction, length of stay, and how they impact the cost saving at the end. So the general administration of pharmaceutical care, that they have a major role in having the important links we can document your inputs, your interventions through the website, which is in the clinical pharmacy. We use was in clinical interventions and put what we have did in the round in a daily basis. After that, the safety medication platform, the antimicrobial steward chip, anticoagulation steward chip, etc. Now coming to real world success story, what we have did recently in Rafah Hospital. So many, before 2 years ago, there was no clinical pharmacist in Rafah Hospital. Nowadays, we have 3 clinical pharmacists, me and Dr. Muhammad Kanaan al-Shammari and also Dr. Bashair al-Sarhani, which most probably they are attending this conference. Now they are leading the 3 main services: ICU, infectious diseases, and internal medicine. So they brought their insights. Medication safety leadership by high alert medication protocols, non-punitive errors, and adverse drug reaction reporting. Antimicrobial stewardship, again and again, antimicrobial stewardship has been improved and implemented actually and effectively. So besides the workflow optimization, task relocation, and capacity building, continuous education, and also the leadership alignment, vision-driven practice. And the most important thing is that the rural pharmacists, they have to have an innovation with the limited resources. Because if you didn't have enough resources, that doesn't mean you didn't innovate. Innovation can be done without or with limited resources. So what the clinical pharmacy services we have input in this year during the 2025 year, clinical pharmacy, 3 clinical pharmacy services that have been implemented: ICO, ID, and internal medicine. Before the integration was high medication complexity and limited time, real-time pharmacist input. The intervention was the pharmacist's participation in the round, evidence-based recommendation, and also direct clinical decision support. After this implementation, we noticed the optimized therapy in critical ill patients, rational antibiotic use were noticed, also the improved clinical outcomes. Now, one of the wonderful things that we have a collaborative practice agreement, and we have created an anticoagulant clinic led by pharmacists. And as you can see, in collaboration with the cardiologist team, also the therapeutic drug monitoring of antibiotics and antiepileptics. The key monitoring is that the serum level interpretation action, dose adjustment based on the patient factors, and pharmacodynamic, pharmacokinetics aspects. Before we implement this or effectively do the therapeutic drug monitoring, the risk of toxicity or subtherapeutics was high and inconsistent monitoring. Intervention, pharmacist-led TDM services, individualized dosing plans, and after that, reduced nephrotoxicity was observed, and also improved the therapeutic outcomes and increased physician confidence. One of the wonderful things, again, telepharmacy services that led by Dr. Ala Mutlaq, Dr. Badr, and Dr. Rashid, they provide consultation or remote consultation via a platform or virtual platform, and covering the diabetes and nephrology patient, and giving the consultation in terms of medication review, dose adjustment, and adherence and counseling. So, in conclusion, clinical pharmacy, what we have did, clinical pharmacy service, anticoagulant clinic collaborative practice agreement, therapeutic drug monitoring. This was in the first quarter of 2025. Telepharmacy also with them. Then at the end of the quarter, the research unit was established and led by clinical pharmacist, Dr. Muhammad Kanaan. And the scientific conference organization, the first Rafha Advance conference of pharmaceutical care was established this year, 1 month ago. And probably Dr. Muhammad Shinawi were there with us. And I will show you a 1 minute of video that what we have did in this scientific conference. كيف يشتغل؟ Seems like So to close, I want to emphasize this. Rural pharmacies are not just healthcare providers, but they are the community anchors. They save lives, bridge gaps, and also ensure healthcare equity where it is needed the most by addressing workforce challenging and expanding clinical services, leveraging technology and strengthening the policy support, we can deliver excellence in patient care anywhere and for everyone. Thank you for your time.
Thank you so much, Abdurrahman, for your nice presentation. Our last speaker, Dr. Khalid Al-Habib. Dr. Khalid Al-Habib is a professor of cardiology, College of Medicine, King Saud University, past president of Saudi Heart Association. Dr. Khalid will talk about from the evidence to action, practical approach to LDL control. So welcome Dr. Khalid to the stage.
Assalamu alaikum. Good afternoon, everyone. So my talk will be about how do we really move on from the evidence regarding treatment of dyslipidemia, particularly the LDL cholesterol, and to really to apply control of this important causal risk factor for heart disease in real life. This is my disclosures. So the agenda today, briefly, we're going to go over the cardiovascular burden in Saudi Arabia. This group doesn't need a lengthy talk about this. You already know this, but just as a reminder. And then we'll talk about unmet medical need in dyslipidemia. And the second part of my talk will be the focusing more on inclisiran as the evidence is evolving as we speak. And then we'll end with the guidelines. So treatment of dyslipidemia, is it a marathon or a sprint? So hopefully at the end of this talk, we'll decide which one it is. So as you know, the global burden of cardiovascular diseases in our region is high. You can see here, the darker the color, the more prevalence of age standardized cardiovascular disease mortality per 100,000. So you can see here that the prevalence is in dark blue in Saudi Arabia, which is 330 to 380 for every 100,000. لكل 100,000 شخص, there are around 300 to 400 people who die. And obviously the mortality rates really varies a lot among different countries in the region. So not all Middle East countries are the same, can be variable as almost 4 to 5-folds in terms of age mortality rates. Ischemic heart disease, strokes are the major causes for death, as you know, and still hypertension is the major cause internationally and in the MENA region as well, in addition to other risk factors such as dyslipidemia. Do we know our cardiovascular risk factors? Well, there are many studies published. This one we have led, myself have led in the last several years as part of the international PURE study, which is Prospective Urban-Rural Epidemiological Study led by Salim Youssef from McMaster. And we have shown that the prevalence of low physical activity, obesity, unhealthy diet, hypertension, diabetes is high. Blue color represents the overall sample, men in orange and women in gray, and you can see the prevalence of low physical activity is over 60%, obesity is high, as you can see, unhealthy diet, hypertension, diabetes, dyslipidemia is around 30%. And this is a study done in the region of Riyadh and Kharj area from the general population. So this is not hospitalized patients, these are from the general population. You can see the current smoking here is way higher in men than women. I do believe that the prevalence of smoking in women is increasing, particularly with the IQOS and vapes and so on, particularly among the youth. Not only this, we carried many registries of acute coronary syndrome over the last 20 years with all fancy names and acronyms. The first ACS registry, acute coronary syndrome registry in Saudi Arabia, started this almost 20 years ago, the SPACE registry, Saudi Project for Assessment of Coronary Events. A lot of registries in the Gulf as well, the Gulf registries. And we collected over 34,000 acute coronary syndrome patients over the last 15 years or so. And we have shown that patients present almost 10 years younger with ACS in our region, and high prevalence of risk factors. It's not 25% diabetes, almost 60% in patients with ACS, and a lot of severe LV dysfunction and severe diffuse disease happening at much younger age. When it comes to dyslipidemia and focusing more on the LDL, as you can see from the graph here, it really matters where you hit the LDL. So you're more likely to drop the curve down and get lower event rate if you actually drop the LDL by 33% at age 40, rather than reducing it by 50% at age 55. So it's not only dropping it to normal, the question is, did you actually hit it early and sustainably over years? And it's called cumulative exposure to LDL. So it's not just that snapshot reduction in 1 or 2 clinics per year. It's rather the reduction over the years and from early age. When I looked at hypercholesterolemia in Saudi Arabia, I summarized it here for you. When you look at the CADIS study published several years ago by Professor Mansour Nuzha, and the WHO surveys carried by the Ministry of Health, and then the latest PURE Saudi Arabia study that I just shown you. And as you can see here, the prevalence, if you take the cutoffs of 30 or 35 years of age and above, the prevalence is around 30–40%. Remember that there are different cutoffs in these Ministry of Health surveys. These percentages were 15 years of age and more. So if you add around another 10–15%, the prevalence would be around 30 to 40%. I just want to remind you, in that older study, which the prevalence is almost 50%, it was only mainly based on total cholesterol. So it didn't go into the details of LDL and so on. So I think it's overestimation. So you can roughly say the prevalence in the general population will be around 30 to 40% max, which is compatible with the diabetes and hypertension prevalence as well. I'm sure you have seen this focus update of the European Society of Cardiology, the 2025 focus update of the 2019 European Society of Cardiology, European Atherosclerosis Society guidelines for the management of dyslipidemia. You can see here in the y-axis the different classes of indications, and the x-axis the risk. So you go from low to moderate to high risk to very high risk, and then they added the extreme high risk, which is something new, which argues that you can actually have a patient where you target the LDL of less than 1 millimole, which is equivalent to 40 milligram per deciliter or less. You have somebody with not only atherosclerotic cardiovascular disease, but with recurrent events or polyvascular disease, which means they have stroke, coronary artery disease, and peripheral arterial disease as well. So these basically needs more aggressive targets than just the very high risk. And as you can see, the very high risk patients, those who are already known to have atherosclerotic cardiovascular disease, whether clinically or by CT calcium score, which is something I do routinely in my clinical practice for those who are coming for primary prevention. And I discover a lot of patients who have subclinical atherosclerosis and they are not symptomatic by doing CT calcium scores. And other patients as well, the familial hypercholesterolemia patients, particularly if they have risk factors. The targets for these patients should be less than 1.4 millimole, which is equivalent to 55 milligram per deciliter. Remember this number because we're gonna go back to it again and again and again. I like this graph because it reminds you about how medications efficacy work, but in isolation and in combination. So if you get a moderate statin intensity, you get 30% reduction, high intensity statin 50%, you add ezetimibe 20%, pimbidoic acid, which is not available in Saudi Arabia yet, around 23%. So moderate reduction with ezetimibe and pimbidoic acid. If you start adding high intensity statin to ezetimibe, you get 60%. And if you add the 333, the PCSK9 inhibitors, ezetimibe, and statin, you can get up to 75 to 80% reduction. So that basically tells you that you can have a good calculated estimation for how much you get in terms of reduction of the LDL in the clinic. There's no point of trying to really wildly guess. You can actually scientifically assess how much reduction the patient can get from these medications. Now, do we actually achieve the targets that I just shown you? So this is a registry that really we spend a lot of years conducting. You were just accepted in publication just a couple of weeks ago. And in current cardiovascular pharmacology. And it looks at the demographics, clinical characteristics, and barriers to care in patients with dyslipidemia in the Arabian Gulf region. So not only Saudi Arabia, but in the whole Arabian Gulf countries, what's called the Gulf Action Registry. And we asked the question, do we actually achieve these targets in primary and secondary prevention? So we enroll patients from both primary care and tertiary care settings in order to try to avoid selection bias. And as you can see, we enrolled almost 3,000 patients, mean age 58, 63% were males. The median follow-up for the first follow-up is 7 months, and the median second follow-up is 14 months. So we didn't only take a snapshot, we followed people for 6 months and 14 months, up to 23 months. So trying to really make sure we're not being biased by getting only the baseline and see whether the care will improve with time. And as you can see here in the far left side and then in the middle and in the far right, we basically describe the proportion of patients achieving the target. So achieving the target is the black color. And you can see from the left to the right, very high risk, moderate risk, and low risk. In this very far left diagram, a baseline, and in the middle diagram, the same results, but at first follow-up, and then in the far right, the second follow-up at 14 months. And as you can see, the major gap comes from the basically very high risk and the high risk patients. So only 20% of these high risk patients that I just informed you, according to major guidelines such as the European Society of Cardiology, only 24% achieve the target. Two, these numbers do not improve with time. It's almost around 30% in the high risk, so minimal improvement with time. So we only achieve the target LDL of 1.4 millimole or less in these high risk and very high risk patients, only in 1 in 5 patients. Why is that? There are many reasons. One of them is we mainly use the statin monotherapy paradigm. We're still treating patients with small to moderate dose statin, then we go up on the dose, which is a failed paradigm. We use combination therapy only in 24% and using the niche drugs such as PCSK9 inhibitors or small interference RNA, glycerin, only in single digit number, around 2 to 4% only, which basically results in not achieving the target and not really following the guidelines. We concluded that very high risk and high risk groups are less likely to achieve their LDL targets. The low use of combination lipid lowering therapy, unhealthy lifestyle, and social factors in the Gulf regions are the main reasons for such poor control. There are countries, areas in Saudi as well, they might have poor access to good care and niche drugs. Strategies are needed to achieve current guidelines recommended targets. Are we that different from international studies and international registries and surveys? I looked at different surveys around the globe and looked at the percentage of atherosclerotic cardiovascular disease patients that achieve the LDL targets. You can see here the Euro-Aspire from Europe, United States, Korea, Da Vinci and Santorini studies led by Koshray from UK, across Europe again, and our Gulf Action Registry in the far right. And these are the targets. And as you can see, we're not that different even from international studies that basically only 20–30% only achieve the target. And the reason is simple. The target is extremely low. It's extremely difficult to achieve it based only on statin monotherapy. So you need additional combination therapy and probably start combination therapy upfront, such as statin and ezetimibe. And then if the patient is still not hitting the target, you move on to PCSK9 inhibitors or inclisiran. Now, this is a study that we're working on. We're finalizing the manuscript. This is Saudi Secondary Prevention Survey study in patients with prior myocardial infarction for S registry. And we involved 5 hospitals. We're still recruiting other hospitals as well. And we did screening for those who had MI, STEMI or non-STEMI, and around 108 patients. We're aiming for 1,000. And as you can see, the uncontrolled LDL again still high, 67%, uncontrolled blood pressure, 54%, referral to rehab, it's around only 25%, uncontrolled blood sugar, 40%, medication non-adherence, 33%, physical inactivity, 71%, high body mass index, 78%, current smokers, 16%. These are people who got a heart attack. And this is 6 months to 24 months follow-up of these patients. So even in these very high-risk patients, there are still persistent patients who still persist to smoke and not drop their weight, and they're having their risk factors not basically controlled according to the guidelines. Dr. Turkil Mekbil and others among our group, we looked at trying to understand why basically we're not hitting the targets. So we distributed a survey among physicians of different subspecialties, family medicine, internal medicine, cardiology, diabetology, endocrinology, saying, what do you think about why we're not, about the dyslipidemia management, why we're not hitting the targets? And the bottom line is this. One, these are physicians talking. Lack of familiarity and knowledge of guidelines, so we're still not really fully aware and knowledgeable about the guidelines and how to apply them. They blame the patient, so maybe patient non-adherence because of side effect, because of social media and so on. Medications costs. Let's really understand that some of the medications for dyslipidemia are expensive. Lack of timely follow-up appointments, government follow-up. My clinic follow-up is in the government after 8 months or almost 11 months. So you don't get a timely follow-up, particularly in the government, and lack of educational tools. And let's address the elephant in the room. Every one of you have a smartphone. You can access anything in the world. So social media plays a major role in staining the reputation of dyslipidemia drugs. Probably some of you are aware of that oncology doctor who went on Twitter and basically starting to attack the cholesterol medication, saying the evidence is not there, it's very wishy-washy, it's not strong. And Minister of Health did a great job by actually forcing him to delete his tweet and announcing a memo in the social media saying statins are safe and effective. And let's do our job. Let's try to educate the public by translating what's getting published in major guidelines into simple plain Arabic. So many patients actually lack proper education. It's our role to go online and actually educate our patients. So we cannot blame this guy who is a doctor, who's not actually an expert at all, if we don't do our job. So we have a lot on our shoulders to do. It's not only this, we have genetics that play a role as well. We just published the Gulf Familial Hypercholesterolemia Registry, and again, across Saudi Arabia and the Gulf. And we have shown that the prevalence of FH, familial hypercholesterolemia, is high. It's almost 3 times the worldwide known prevalence of heterozygous FH. The worldwide known prevalence is 1 in 300. In our study, it was 1 in 112. And only minority, almost around 12%, achieve the target of 1.4 millimole or less. And if FH patients have risk factors, which is FH very high risk, they are less likely to hit the target as well. This Gulf FH registry has been part of a major international familial hypercholesterolemia registry published in The Lancet, led again by Koshray and published in The Lancet several years ago, that has shown that we underestimate and undertreat patients with familial hypercholesterolemia. And only single-digit number of patients achieve the targets in familial hypercholesterolemia. So it's not only lifestyle, we have also issues related to FH, maybe it's related to high consanguinity, maybe it's a founder effect. But we have to really pay attention to this. I'm part of a committee related to هيئة الصحة العامة وقاية, and propose to them to really do a screening, not only at middle age for dyslipidemia, to do what's called reverse cascade screening, where you screen children. So the child basically will be the index case leading to discovering his or her parents at younger age, in addition to doing other initiatives as well to diagnose dyslipidemia. This is the first part of the talk, and then we'll focus more on how could we address it by using combination therapy and using this novel medication, the inclisiran. Can't go into inclisiran without really acknowledging those 2 people who won the Nobel Prize in 2006 for the discovery of RNA interference, gene silencing by double-stranded RNA, which is really a novel methodology that's being used now, not only in dyslipidemia, but in other diseases. Great medications are being developed that really save the patient from taking daily medications or monthly injections. You all know this, how statin works, working on the MG-CoA reductase, PCSK9 inhibitors of alirocumab already well established, the reduced cardiovascular outcomes, and basically by inhibiting PCSK9, and by that they basically upgrade the LDL receptors over the liver surface, and by that increase uptake of the LDL into the liver, and by that reducing the LDL in the blood. Well, basically inclisiran works the same by reducing the PCSK9 synthesis, but more upfront in the pathway by working on gene silencing, and by that basically inhibiting more efficient inhibition of the production of the PCSK9 and hence reduction of the LDL in the blood. This is the same figure, but basically more focus on this receptor, the glycoprotein receptor, which is very specific to the inclisiran. You have very high affinity of inclisiran to this receptor on the liver, and by that, after 48 hours, there's not much of inclisiran in the blood, and it's all in the liver, and by that you have the long action for inclisiran over several months, 6 months, hence the twice-a-year injection protocol. This group knows about the Orion program, Orion 9, 10, and 11. Orion 9 was heterozygous FH patients, if their LDL above 100 milligram per deciliter. Orion 10, atherosclerotic cardiovascular disease, LDL above 70. Orion 11, not only atherosclerotic cardiovascular disease, but those with atherosclerotic cardiovascular disease risk equivalent. So they have type 2 diabetes, 10-year risk more than 20%, heterozygous FH, and their LDL more than 70. These are already numbers are unheard of even around 10 years ago, and yet the trials were done to achieve even lower LDL. So these numbers were okay for us as physicians almost 10, 15 years ago. And yet these studies actually challenged the concept that these LDL targets are actually still high, and we need to lower them further above and beyond a baseline statin therapy. And results were published in the New England Journal of Medicine for Orion 10 and 11, showing 50% reduction in PCSK9 and the LDL. And also for Orion 9, the heterozygous familial hypercholesterolemia, 50% reduction in the LDL with the FH. How about in real life? Not only randomized trials, this Orion 3 trial followed people for years in real life, and it shows that over 4 years, you still have persistent reduction in real life patients in the LDL, even after you switch from evolocumab, and basically with the conclusion that there is sustained reduction, no concerns about safety as well, just a slight pain, slight pain at the injection site. People always say, well, we don't have evidence about cardiovascular outcomes. Well, let's wait for the cardiovascular outcomes similar to other PCSK9 inhibitors. Well, we do have some evidence, despite this being underpowered, still published in the European Heart Journal, and they pooled the Orion 9, 10, and 11 data together, which have shown that inclisiran did reduce LDL significantly and reduced the MACE, the major cardiovascular outcome. Obviously, that this pooled analysis is hypothesis generating. It's not powered for a myocardial infarction reduction or stroke. So hence the line was crossing the line, the data were crossing the line of unity. So non-significant results for fatal, non-fatal MI, and non-fatal stroke, with a very reasonable conclusion of the authors that this analysis offers early insights on the potential cardiovascular benefits of LDL cholesterol reduction and suggests potential benefits of MACE reduction. We're still waiting for the major trial, the Orion 4 randomized control trial, which is a 15,000 patient trial of inclisiran versus placebo with a hard outcome, CHD death, MI, stroke, or urgent coronary revascularization. And this is a trial, hopefully by 2026, will be published and will basically have a closure to this great story of inclisiran of reducing cardiovascular outcome. Going back to the, again, to real life, this study again confirms the safety and the efficacy of inclisiran. And another question always comes with these drugs: do they actually have resistance over time? Do they produce antibodies? Do you lose efficacy? And you can see here only 5.5% have antibodies produced and were not associated with increased incidence of treatment-associated side effects. This study was published in JACC, Journal of American College of Cardiology, inclisiran first strategy versus usual care. So this is a neat study where basically the trial is said, well, if we start upfront inclisiran in a patient who is statin naive, no statin. And we told physicians, try your best, try to control the LDL by the usual care versus inclisiran. And the inclisiran was actually more effective in reducing the LDL cholesterol compared to the usual care. If you start with the inclisiran first strategy. Again, another try by pooling the 7 clinical trials of inclisiran, showing again safety published in JACC in 2023. And this study basically looked, how about if we add inclisiran to ezetimibe and statin, you get dramatic reduction of almost 70%. And Victorian Mono, published in May 2025, compared to ezetimibe, which is modest reduction, as you know, of around 35%, you get almost 50% reduction by inclisiran, demonstrating for the first time that patient not receiving lipid-lowering therapy, inclisiran as monotherapy is superior to placebo and ezetimibe. How about our own real world in Saudi Arabia? We conducted this registry, is still ongoing, along with other cardiologists in Saudi Arabia. And I presented this in the International Society of Atherosclerosis in Oman last year. And as you can see, the preliminary results shows a reduction of LDL of around 50% in patients with atherosclerotic disease or familial hypercholesterolemia. We're targeting above 300 patients on inclisiran, receiving the 3 doses of inclisiran. So as you can see, we're moving the paradigm from using a lot of tablets, daily tablets, to monoclonal antibodies twice a month or once a month, to twice a year, and hopefully maybe gene editing, hopefully in our lifetime. And that will increase adherence of our patients to the medications. I usually say drugs are great as long as they are taken. So it doesn't help if you have randomized trials that showed benefit and reduction in outcomes, and yet patients are not taking them, or they don't want to inject themselves, for example. So quick myths about inclisiran, that it plays with your gene. This is wrong. It only works on RNA, it doesn't play with your DNA. It causes long-term side effects because it's a long-acting drug. This is not true. We have I've shown you with multiple studies published in major cardiology journals that it is safe. It's less effective than PCSK9 inhibitors. This is not right. It's only, you do assess that in real-life registries. I've shown you locally and internationally that you don't lose the efficacy of, even if you switch. Cannot be used till we get a positive cardiovascular outcome study. It depends on you. If you're a purist, you might say, well, I want to wait for the outcome study. My take on this, I've been using it since 2019. It was introduced in December, actually, 2019. The first patient in Saudi Arabia was actually in my clinic on inclisiran, been using it for years. It's very efficient, so good in reducing it to the level that I'm actually going down on statins and ezetimibe medications. Alternative to statins, it's not an alternative to statins. You might reduce the dose, but you don't stop the statins. Quickly, the recommendations. This is the latest 2025 focus update again of the European Society of Cardiology. They basically elected to focus only on those with cardiovascular benefit, so non-statin therapies with proven cardiovascular benefit, i.e. PCSK9 inhibitors, ezetimibe, and pemvidouic acid, which I don't think it's fair, because if you look at the next slide, the Americans, again 2025, and they look in the middle graph, they basically say if you use the LDL more than 70 in those high-risk atherosclerotic cardiovascular patients, you can use PCSK9 inhibitors or inclisiran. And this is highlighted in our Saudi dyslipidemia guidelines. We're working also on this guideline, still not published yet, from the Saudi Heart Association on PCSK9 targeted therapies. And it's complicated, but you can see in the middle and the far right graph that if the patient is still high risk, you can use PCSK9 directed therapy, either inclisiran or PCSK9 inhibitors. So, ladies and gentlemen, is the LDL story is a marathon or a sprint? It's a marathon. It's not one snapshot, you treat the patient and you forget about it. We heard from a nice speech from Dr. Abdurrahman, the previous speaker, that rural areas, it actually fits very nicely for those in the rural area. You take the drug, it controls the LDL for basically the whole 6 months, so you don't really think a lot or get obsessed about the patient LDL cholesterol. So this is another way of achieving the LDL in those living outside urban areas. Take-home messages: we have high burden of cardiovascular disease, particularly at young age. Cumulative LDL cholesterol over the years is an important concept, not just a snapshot. LDL control: most of the high-risk patients, i.e. atherosclerotic cardiovascular disease, FH, high coronary artery disease risk factors, do not achieve the LDL targets. I've shown you only 20% achieve the LDL target to 1.4 millimole. Inclisiran, similar to the PCSK9 inhibitors, is a paradigm shift in the way we treat patients, not only very effective, but safe and sustainable LDL reduction. And we're awaiting the Orion 4 cardiovascular outcome trial outcome next year, inshallah. Thank you very much for your kind attention. الله يحفظك.
Thank you so much, Dr. Khalid, for your presentation. Now it's time of discussion. Dr. Fuad and Dr. Abdurrahman Al-Shamri come to the stage. Questions? So my question to Dr. Fuad.
It's a question here.
Dr. Ali Sabir. Mike.
Assalamu alaikum. Thank you all for this great presentation. Actually, I don't have a question. I have a thank you letter from, I think, everyone in Saudi Arabia to every single pharmacist or medical field that works during Al-Hajj. It's a mass gathering that everyone in the world that looks toward. And we every year we, let's say, we conquer another milestone. So thank you all for everything that is done during Al-Hajj. You make us all proud. Every single operation done, every single medication dispensed, every patient care done during Al-Hajj is really, really something everyone should be proud of. So thank you all in Mecca Health Cluster and every single volunteer during Al-Hajj.
Thank you so much for your. So my question to Dr. Fuad Bahamni regarding to your experience. Well, when you are comparing about the healthcare professional under the MOH and outside regarding that participated in that mass gathering, can you give about your experience regarding the pathway between these two groups?
Thank you. I think now I'm on. Thank you, Dr. Mane, for this great question. I think I briefly highlight the importance of having a bridge between both MOH and Mecca Health Care Cluster. The operation and the policy making or the decision making has definitely to be aligned. And we do a lot of meetings prior to the Hajj seasons and during and even after to ensure that bridges of communications is always on. I think that would be my straightforward answer to that question.
Great. Regarding Dr. Khalid, I have one question. What's the recommended place in therapy for inclisiran compared with the monoclonal antibodies such as ifilocumab, recently released DCBD guidelines for patients with following acute chronic syndrome? About comparison between this one. What's the recommended in place in therapy?
Yeah, so if you look at the American College of Cardiology guidelines that I have just shown, the 2025 acute syndrome guidelines, they actually put the PCSK9 inhibitors or inclisiran on equal footing. So if the patient with atherosclerotic cardiovascular disease, you think that their LDL is too high to be dropped by a statin when a patient gets admitted, for example, and a patient with ACS comes in, he's statin naive, this is the first time, and their LDL is 5. So you know you're dealing with FH till proven otherwise, familial hypercholesterolemia. The recommendation is actually maybe you need to start with triple therapy. While if the patient is already on a statin, you can add ezetimibe and then follow the patient. If the patient still not controlled, you can add a PCSK9 inhibitor or inclisiran. Have to say the evidence for acute syndrome patients, you have more trials in ovolocumab and alirocumab than inclisiran. There are abstracts presented at conferences about inclisiran in acute syndrome patients. But if you believe in LDL reduction, it really doesn't matter which agent you use.
Okay. I received one question in the app. One question, there is one patient was on triple therapy, statin and azacitidine and PCSK9. And he reaches the target, would discontinue the azacitidine or plus PCSK9 or no, based on your experience?
What I do is basically, if the patient, for example, hit the target, i.e. less than 1.4 millimole, some patients are like 0.5 or 0.6, extremely low. The first drug that gets out is ezetimibe, which is a weak medication. It's only reduced by 20%. I keep the statin and I keep the PCSK9 inhibitors, so you don't lose the control. And I reassess the patient in 6 weeks' time. However, if the patient is already 1.4, 1.3, I don't stop any of them, because you're going to lose the control if you stop any one of them. So it depends. If it is really, really low, extremely low, have patients like 0 or 0.1. So I think these patients, you do not need to go to these extreme levels. You can stop the ezetimibe.
Great. My question to Dr. Abdurrahman Al-Shammari, based on your experience in your remote city, what are the most challenges that you are faced, because you are only 3 clinical pharmacists up to my knowledge? Can you give me some points that you are see your challenge or difficulties during your practice?
So you are talking about the challenges.
Yes.
The challenges was in the clinical pharmacy integration at the beginning of our, when we are finished our study. It was the introduction to the medical team, which is there was a resistance from the medical team toward the clinical pharmacist. Then I will call it in 3 phases. The first phase was resistance phase from the medical team. Then the adaptation phase after the enforcement of higher administration of the hospital and medical director by engaging the pharmacist to incorporate it into the clinical team or multidisciplinary plan. The last phase was they are not starting the round if you are not here. And literally, I'm saying that they are needing you more than you need them in terms of medication or treatment plan. So this was the big challenges, and we overcome it, alhamdulillah.
Great. Really, I am proud of Rafha Clinical Pharmacist. Only 3 clinical pharmacists, established conference, established services. Really, thank you so much. Now I received, there is no time. By the end of this session, I would like to thank to Dr. Khalid Al-Habib and Dr. Fouad Bahamdeen and Dr. Abdurrahman Shammari. Thank you so much, the audience, for your attendance and your question.
If you allow me, Dr. Mana, I have mentioned one of the great services that led by General Administration of Pharmaceutical Care, led by Dr. Ala Mutlaq, which we are discussing before 2 hours ago. Telepharmacy, which is very helpful and very impactful in those areas, rural pharmacy. So I would like to invite Dr. Ala to just give us an introduction and insight about what is the service and how to implement in the rural areas for those who are not yet implement So, Dr. Ala, if you can give us a brief introduction.
Thank you, Dr. Abdurrahman. Actually, we started this
صوت
services.
صوت.
We started this services 2 years ago. We, as you say, at the beginning we have a resistance. What is the role of clinical pharmacists in the virtual clinic and why we need these services? But at that time, alhamdulillah, there is some of clinicians came from King Khalid Hospital, and they are actually asking for a clinical pharmacist to be with them in this clinic. So we just started this clinic, and we have a patients referred from the physician clinic. At the beginning, only we have 2 to 3 patients per week. And within the time, alhamdulillah, we have a full capacity of our clinics. Last year, we have around 300 patients in diabetic clinic and also in nephrology clinic. And the end of 2024, we starting the sharing clinic with Rafah Hospital. We have patients from referred from the hospital scheduled in the clinic. Then we just share the clinic with either the physician or clinical pharmacist. We contact with the patients through the platform, which is Raqim. And then, actually this Raqim integrated with Anat platform. So we just, we contact the patients, we put the plan with our colleague in Rafah Hospital, and they directly enter the intervention to the system. And also there is something, make it more easy for the patients. We just tell the patients, go to the hospital now to take your medication. It is ready in the pharmacy already. The pharmacist there already take that prescription, and and the medication available as well. So alhamdulillah, this year I don't have the full number of the patients, but we do a great job, and we will inshallah expand for other services and for other hospitals, especially rural hospital. Thank you, Dr. Abdurrahman. Thank you for all.
يعطيك العافية دكتور علاء. Thanks so much. Questions? Again, thank you so much, Dr. Khalid. And thank you so much, Dr. Fuad and Dr. Abdurrahman, for your nice presentation. Also, thank you so much for all the audience for your attendance and questions.
Thank you, Dr. Manik.
Before we conclude, we would like to present a token of appreciation to our moderator and speaker for their valuable contributions to this session. We kindly invite Dr. Saeed Al-Ghamdi to join us on stage to present the certificate of appreciation. We will begin by recognizing our speakers. First, we would like to invite Dr. Fuad Bahamdeen to the stage. Next, we would like to invite Dr. Abdurrahman Al-Shamari to the stage. Finally, we would like to invite our session moderator, Dr. Mana Faris Al-Najib, to the stage. Thank you, Dr. Mana, for your outstanding leadership, thoughtful guidance, and for moderating this session with clarity and excellence. And last but not least, we would like to invite Dr. Khalid Al-Habib to the stage. This concludes session 9. We extend our sincere appreciation to our moderator and speaker for sharing their experiences and perspectives on the diverse and evolving opportunities for pharmacists across Saudi Arabia. Thank you to all attendees, and we will now proceed with the scheduled break for 20 minutes. We look forward to welcoming you back in 20 minutes for the upcoming sessions. Actually, we will proceed now with the next session, session number 9, session number 10.
تست. السلام عليكم ورحمة الله وبركاته. Ladies and gentlemen, it's our great pleasure to have you today. I am Abdurrahman Lafi Rashidi, and I am delighted to welcome you all. Session number 10, Lecture 1, Managing Imposter Syndrome and Building Confidence as a New Graduate. Lecture 2, The Innovation Mindset, How to Foster a Creativity Culture in Pharmacy Practice, moderated by Dr. Ahmed Al-Demirdash. Dr. Al-Demirdash is an Assistant Professor of Clinical Pharmacy in College of Pharmacy, King Saud University, and Cardiovascular Pharmacotherapy, Pharmacy Specialist at King Saud University, Medical City. He also served as Chairman of the Pharmacy Program Unit and Chairman of the Pharmacy Fellowship Route and Director of the Cardiology Residency Program. Dr. Al-Demirdash received Bachelor degree in Pharmaceutical Science from King Saud University and PharmD degree from the United States. He completed his BGY1 and BGY2 Brigham and Women's Hospital, United States. He currently serves as the chairman of the Pharmacy Science Council and advisor of the Secretary General at Saudi Commission for Health Specialists and board member in the Saudi Society of Clinical Pharmacy. Please welcome Dr. Demirdash.
السلام عليكم. أسعد الله مساءكم جميعا بكل خير. First of all, I would like to thank Ihop for the invitation and for outstanding preparation as usual. It's always a pleasure to be here. Thank you, Dr. Mohammed Al-Shinawi, for the leadership. And thanks for having me moderate this session that is very unique. It takes you all the way when you start with doubts about yourself, about your capacity. How can you build this confidence and how to move forward all the way to a very unusual era, which is innovation and creativity in the workplace in pharmacy. Our first speaker, I'm going to be introducing Dr. Osama Tabara, who has 37 years of corporate and 3 years of entrepreneurial experience in pharmacy. He's a founder of the IVPN network with 28,000 members, and he served as executive director of pharmacy at Cleveland Clinic Abu Dhabi for 10 years, and also a director of pharmacy services at King Fahd Medical City for 4 years, and the Mafraq Hospital in Abu Dhabi for 3 years. And additionally, he worked at King Faisal and Research Center for 11 years and Al Hada Military Hospital for 9 years. That's a lot of 37 years experience. Dr. Osama is also an adjunct clinical assistant professor at Gulf Medical University and advisory board member in 4 UAE universities. He's a graduate from King Saud University in 1984. He earned his nutrition support board in 1997, executive MBA in 2014, and he holds 12 publications and has spoken at over 180 symposiums and 1,000 presentations on various clinical and leadership topics. Please join me to welcome Dr. Osama.
Bismillah ar-Rahman ar-Rahim. Dr. Demirdash, thank you very much for the nice introduction. I would like to thank the organizing committee, Dr. Muhammad Shinnawi, and the team for the precious invitation to be part of this amazing event. One moment. Okay, please raise your hand if you ever read or heard about imposter syndrome. Imposter syndrome. Yeah, almost 50% of the audience. And I will start with the definition. How common is imposter? The root causes of imposter, and like 10 quick real scenarios from the bedside and from the work side about imposter syndrome. So what is imposter syndrome? It's feeling like a fraud despite success. يعني ممكن الواحد يقول أنا مني أصلي. I feel إنه أنا kind of مزور إذا بدي أترجمها للعربي. Fear of being discovered or exposed as a fraud. And self-doubt, and nothing worse than ضعف الثقة بالنفس despite education, experience, and accomplishment. So it hits the accomplished people and not deserving the accomplishments. So someone get a promotion, he tells you, oh, I don't deserve this promotion. I believe many people are better than me. I don't feel the judge were fair. You see, there is a kind of confidence issues. So the imposter believe that I must be perfect to be successful. So they always, think about perfectionism. They always feel that failing is not an option for me. So they have the fear of failure, and they always question if they are good enough. So they have a self-doubt. So what is the internal critical voice here? They tell you, I don't deserve my high grade if they are students. You see? ما بستاهل العلامات هاي. I can't see on the screen here. Can someone help me because the screen is black? خليني نكمل هون. شباب, no screen here. Okay, I will continue from you. So the inner voice, I am fake and I'm not good enough. I don't think I am smart enough. I don't deserve the attention. You know, we heard these things many times during the mentorship sessions, and they tell you, I feel others, they know more than me. I fear asking or sharing my ideas. And in the extreme way, they tell you bluntly, listen, my mentor, I feel like I am stupid. So, and many of those imposters, they tell you, really, I'm just lucky, somebody else would have done a better job. And doubts kills more dreams than failure ever will. And there's nothing worse than really having a confidence issues. So the fact that imposter syndrome is not a disease or abnormality, it's not necessarily tied to depression. You cannot say I'm depressed, I am imposter, that means I have a depression. No, it's not a depression. Many depressed people, they have imposter, but it's not necessarily that if you have imposter or self-doubt issues that you are a depressed patient. Imposter is not limited to juniors, and this is a very important statement. It may happen among many seniors. And the best thing about it is really to speak about it. You need to have a mentor and you need to be close to the mentor. So whenever you have a self-doubt issues, go and tell him that, you know, I feel like I have a self-doubt issues. So self-doubt is really universal human trait. It is the successful person who tends to suffer from it. And we've seen it many times with our kids, with students, that despite ranking the first place, they feel like I'm not really feeling that I am in the first ranking. I like this, what's mentioned here, because it gives a lot of hope. Am I even good enough to have imposter syndrome? This tells you that those imposter people, they are really good people in origin, and they are successful in their life and in their careers. And behind every seemingly perfect person, there is a mess that you cannot see. Like any carpet, you see the carpet in front, it's perfect, and the backside, you know, it's really not the same as it is in the front. So why it matters for young generations, particularly the millennials and the Gen Z, because it truly affects the confidence, it delays career growth upon graduation, and it causes a lot of stress and burnout. And I really want you to reflect during this presentation if you have kids and to discover if they have self-confidence issues, because it really will have impact in their career later in life. So why it matters that we have to offer mentorship to millennials and Gen Z? Because they really value the feedback and they struggle often with self-doubt in fast-paced environments. How common it is, or is it? It is 70% of people experiencing it. And it's very commonly seen in students, leaders, professionals at all ages, and it rates very high among the ethnic minority group. I personally took the survey. I really recommend that you Google and get the survey and check if you have elements of imposter. Personally, I took it. It tells me that I have few imposter syndrome characteristics. I always felt that I'm confident, but when I took the survey, I felt, yes, I sometimes have imposter, especially when I worked with micromanagers or micromanagement leadership. So let me see a raise of hands here. Have you ever felt like imposter? Please say the truth. Raise your hand if you ever had imposter in your lifetime. Trust me, more than 80% will have imposter. And leaders will have so many times imposters. And I will tell you why leaders, before the juniors, they have imposters. First is the family dynamics. Those families who want much, who set a very high expectation from their children, they induce a feeling of imposter among their children. Academic and workplace pressure, always put yourself in imposter. The seniority, there is increased level of responsibilities, especially when you are accountable for outcome. When you need to present data, it induces imposter. And nothing worse than a micromanager leader to induce imposter among his or her subordinate, and not being addressed as a culture by the human resources. And very importantly, the social media comparisons, it kills really the new generation and let them feel that they are always in comparison, and this will induce imposter. So the AI and social media truly induce imposter, especially with the job displacement issues with AI, that like I feel now my skills are less valuable, I will be replaced anytime. Or with the comparative culture, when I see the success of others on social media, I feel inadequate. And this happens to me, it happens to anyone. You know, when you see the successful people on social media and you say, why not me? You know, what's wrong with me? Probably I'm not really good enough or whatever. Expectations of perfection, because AI creates environment of perfection, and you know it induces that say that I'm not up to it. It affects many personality types. Those super person who push themselves very hard, the super people, in a way to prove that they are really super. But unfortunately, the first incident of failure, it put them in imposter. The go it alone person, those people who are not asking for help, they feel that they know everything. Those people, when they go for help, they think that they are weak, and those will, by time, they will develop fear of imposter. The genius, because of the when they get a difficult task, this might induce a fear of imposter if they don't accomplish as expected. The expert with their confidence issues, they always go into imposter syndrome. And the perfectionist, because either 100% or not, so you submit a 200 pages document, and then few people criticizes you. This criticism induces a feeling of imposter among the perfectionists. Keep in mind that 94% of those who have suffered from imposter syndrome say they haven't discussed their feeling at work. And I truly recommend to have a theme of the month in your institution and speak highly and loudly about imposter syndrome. 61% of those that are uncomfortable telling their manager their feelings fear that they could be seen as a less capable employee. This is very dangerous. So when does it happen at most? It happens when you get into a new job, when you have a new career, and when you have a new boss, particularly a bad boss, a toxic boss, a micromanager boss. So how, myself as a mentor, can I identify the imposters? Listen, they always add new degrees to boost their CVs. Surprising, right? Achievers, they are achievers, but they want to add more to their CV to prove that, no, I'm confident enough, but the inner voice tell them they are imposters. Not involving in new projects, it happens. I'm not really going to go into new projects because, really I'm not good enough. Other people are better than me. Refusing promotions and leadership roles. They are often workaholic to prove that they are not imposters, to prove themselves that they are really effective. They work long hours. They avoid opportunities sometimes. They don't apply for promotion. And sometimes they exaggerate their accomplishments, particularly on LinkedIn, etc. We see this a lot, by the way. So what do you do if you have imposter? You need to understand that you have imposter syndrome. You need to have a mentor, and you keep trying to get better in things you are good at. Let's go into real-life scenarios, quick real-life scenarios. Sarah feels intimidated during multidisciplinary team meetings. Even when she knows the right drug recommendations, she hesitates to speak up, fearing rejection by doctors. It happens to every one of us when we soon join a multidisciplinary team meetings. So the mentor, as a mentor, I say, Sarah, please, I encourage you to prepare evidence-based guidelines to support your case. And Sarah, please respect in team growth from consistency, not one-off comments. Don't let one comment affect you. Another real-life imposter scenario, Khalid, he just had his first research article accepted. Instead of celebrating, he feels it's not a big deal, and others have done much better. I've seen it a lot among my team as well. So what do I mentor? How do I deal with Khalid? I tell him, please celebrate openly, be proud. Publication is a major achievement. Khalid, you need to compare your current self with your past self and not with others. Khalid, try to mentor juniors on research writing and make an impact. Another case scenario, Noura was promoted to head of pharmacy department. Despite strong qualifications, she doubts she can lead older, more experienced pharmacists. It happens to me, it happens to every leader upon new promotions. So what do we recommend? Leadership is about collaboration, is not about knowing everything. Noura, you have to listen first and make a small, confident decisions, make a quick wins, and please celebrate those quick wins. Shadow with other leaders for confidence. Hadi, a new clinical pharmacy lecturer, feels like an imposter teaching students because he doesn't have decades of practice experience like senior professors. This is an imposter. So Hadi, your students are definitely benefiting from your deep and fresh knowledge and enthusiasm. Hadi, teaching is about guiding, it's not about all knowing. Another case scenario, Muna, she just started her first hospital job. She feels overwhelmed by physicians' questions during ward rounds. It happened to all of us during the first multidisciplinary rounds. She worries she isn't clinically enough prepared compared to senior colleagues. What do you tell Muna? Muna, learning is a journey, it takes time. Muna, you need to prepare well before rounds, and you need to ask one question per round initially to build confidence. Another life scenario, Ahmed is a PGY2 critical care residency. Despite excellent evaluations, he feels he doesn't deserve to be in the program. It happens a lot to many of the pharmacists seeking residencies. He believes that he was chosen by mistakes. So we tell Ahmed that you need to highlight the competitive selection process. You need to believe that the process of selection is very competitive and that you earn it, the position. And you need to set performance benchmarks so you see your growth in it. Rania has been invited to present at an international congress. She considers declining, fearing she is not expert enough and others will judge her knowledge. Also, it happened to me, it happened to many pharmacists. We tell Rania that your perspective is unique and valuable to build the confidence in herself, and we help you preparing and rehearsing with the feedback. Rania, even great leaders get nervous before big talks. Two more quick scenarios. Sarah feels her success is just luck. She avoids applying elsewhere now for promotions. We tell Sarah, you always earn it through skills, not luck, yeah, Sarah. And you encourage you to apply for small challenges first and to track and document the achievements. Layla fails her big projects and she wants to quit. Yeah, Layla, this is not your rehearsal. This is your rehearsal, sorry, and it's not your final show. Let's analyze the lessons learned. And Hassan always hides questions with fear of looking stupid. So Hassan, don't worry, please. Questions show curiosity, not weakness. And yeah, Hassan, I always ask questions as a student. And the final real life imposter scenario is Omar, who works in a busy community pharmacy. A patient asked tough questions about drug interactions. Omar gave the correct answer, but later doubted himself and replayed the whole event in his head. So we advise Omar to always double-check references, not as a weakness, but as a good practice. And yeah, Omar, the patient values clarity and not perfections. So the call to action for mentees, I'm done, almost done, is to have to speak about doubts. You need to ask for help from a mentor. You need to believe in the progress and not in the perfection, and always believe that the perfection is the enemy of good. You need to be patient and give time to yourself. You need to discover your skills and quality with the help of a mentor and discover your core strength here. You need to build identity. You need to establish visibility on social media with guidance of the mentor. So people will label you as the king of infectious disease, the king of parenteral nutrition, the king of, etc. And you need to convince yourself, if you are an achiever, you are not an imposter. So the key to success, you need to replace I'm not good enough with I am still learning, and you need to focus on the effort and not on the perfection. The last slide, what is the role of leadership here? You need to create a mentorship program at your institution. You need to provide workshops on resilience. You need to recognize the achievement publicly of your team and of your individuals. You need to foster a trusting environment, and you need to work with HR to establish a speak-up culture. With this, I conclude, and thank you very much.
Thank you, Dr. Osama, for the scenarios and for sharing the keys of success. I'm sure we're going to have a very nice discussion in the Q&A session. We're going to move to our second talk with Dr. Fahad. Dr. Fahad is a clinical pharmacist and a medication safety officer at King Abdullah Medical City in Holy Capital in Mecca. Dr. Khalid is the acting supervisor of the Pharmacy Informatics and Automation in Mecca Health Cluster and a founding member in the Saudi Health Informatics Pharmacists. Dr. Khalid earned his Doctor of Pharmacy degree from Al Qura University, College of Pharmacy. He completed his PGY1 pharmacy residency at King Faisal Specialist Hospital and Research Center in Jeddah, and is currently a PGY2 in Medication Use Safety and Policy in King Faisal Specialist Hospital and Research Center in Riyadh. He is certified associate in Healthcare Information and Management Systems from the HMISS and an American Board Certified Pharmacotherapy Specialist, PCPS. Please join me to welcome Dr. Khalid. Dr. Fahad.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Ahmed, for the kind introduction. So today we will speak about the innovation. I think it's a perfect segue to Dr. Osama's presentation from building the confidence as a clinician or practitioner all the way to having your successes to be introduced as innovation and to build the mindset to continued success. So I have no affiliation or financial interest in or conflict of interest in the presentation. So our agenda, it will be a light-hearted presentation, hopefully, inshallah. So the agenda will first recognize the common myths that limit innovation in pharmacy. We'll understand the mental status or mental state, sorry, that influence the creativity. And lastly, we'll explore practical tools that any leaders or any innovators can use in their practice to foster the culture of innovation in their environment. So the question, and for the sake of time, we'll keep it short. Who's responsible for the innovation in the workplace? Is it the frontline employees, your employees working in the pharmacy, dispensing medication? Is it the HR department who are working in the hospital? Will it be the leaders who are responsible for the innovation? Or lastly, external consultant outside the institution who are working with the pharmacy to ensure innovation is ongoing? So before we answer this question, let's talk first, what is innovation as a word, as a definition in the literature? So there are a lot of definitions when I searched about the innovation or the word or definition scientifically about the innovation. The first one was they talked about how it's multifaceted and dynamic synthesis of technology advancement and research and evolution of the delivery system in the pharmacy or patient care in general. The second definition was the novel approaches, which is very short, novel approaches creating positive health impact. And lastly, even the WHO, they chimed in and they said it encompasses the introduction and implementation of new ideas, processes, products, or technology in the healthcare setting. So all of these definitions are clear, and I think even in the literature, there is no universal definition to define what is health innovation. Some of them will say it's technology-based, some of them will say it's creativity-based. So far, we don't have a clear say on this in terms of innovation, but suffice to say in this slide, keep in mind that the innovation, it encompasses all of those definitions, and it's transformative. So you have to take care that the innovation encompasses unique complexities and challenges in this context. So responsibility, I would say it falls both in the frontline employees and leadership. Obviously, I think it's not 50-50, but I think both of them has to collaborate to ensure innovation in the workplace environment. In the slides, I will go through all the myths. So the first myth we already tackled, which is the only frontlines can innovate. I think we already established that the leadership and frontliners, they can both collaborate to achieve or to innovate in their workplace. The second myth is that the healthcare environment or the healthcare field is not a creative field. I would hardly disagree because we see all of the, in our practice, in daily practices, you will see we deal with complex patient problems. We also try, especially in those who work in the quality or safety field, we try to redesign the workflow to reduce errors, to improve safety and enhance care. And lastly, we are in the field that adapt to fast-changing environment. We see just a couple years ago, we are introduced to the prospect of AI, and now we are seeing it used daily, be it in patient care. Some institutions they already try to use it, and even in the Hajj. I think Dr. Fuad presentation he also mentioned this. So we can see that the innovation is fast changing, and the healthcare field is nevertheless a creative field in this regard. So the last myth I would say it's the innovation means using cutting edge technology. Usually when I say innovation, a lot of you will think it's using the most advanced innovation solutions in your pharmacy. Also, I would think, no, this is not the correct way to think about innovation. Innovation requires creativity, requires empathy, and requires observation of the workplace environment you work in to see how you would think differently about the process you are dealing with. So I think one of the things I saw in the literature that caught my eye during preparing this presentation is that one of the landmark articles published in Harvard Business Review, they talked about how to ensure a playful mindset which can boost the creativity in your team. They mentioned the word fun, and it's a prerequisite to having a creative behavior, which definitely will lead to innovative mindset. So the fun aspect of the innovation is crucial to ensure you have a creative behavior and a creative environment. So how would you think you would make your workplace fun? Some of you, I think, they would imagine something like this. It's not actually to be exactly in this image. However, you have to think outside the box. How would you implement the word fun in your workplace environment? The issue with innovation is that most of us, when we are working in our daily task or daily work, we think about the perfect resolution. We think about how our project will end up in the finishing line. However, when we finish the project and we think we have finished and we close the file for this project, we think, I didn't do this project in the most optimum way. I think there is another solution in this. You would never reach this resolution because while doing this project or this task, you are dealing with a lot of complexities, a lot of tasks that hinders the innovation mindset in this. You have to switch from the state of mind of trying to accomplish all the tasks in a timely manner. Not just that, but try to unlock the state of having to think, to stop and think differently about your project or your process that you deal with. Also remember that the most people who know about the process or the process or the workflow you want to innovate are those who work in the field. So it's important for you, for leaders and even for frontliners to be involved in the field and to get their experience from the field to try to innovate your workplace environment. So what are the tools, the toolkit you would need to start introducing the idea of innovation in workplace environment? It's three things, and it's the most crucial three things I found in the literature. These are what I collected from the literature. It's not one size fit all toolkit. However, you try to implement all of those toolkit as much as you could. So the first one is the raise intellectual bravery. think inside the box, and lastly, to embrace serendipity. So the intellectual bravery, you can introduce it in your workplace by taking the finger off the fear button. Most of us, even the leaders, they think the workplace is doing well and we don't want to interrupt any task or any work that's being done in a daily manner. However, they think that when you try to innovate in your workplace environment, errors may happen. But try to take off this fear button and trust your employee about their innovation and trust their innovative mind to start working and innovate in your workplace. Assign dissonant, which means we are trying to avoid those who would disagree with you a lot. You have to involve those who would disagree with you, especially when you're trying to innovate in your workflow environment, because discussion and open communication are crucial for innovation. Encourage people to think beyond their roles, especially those in frontliners. They will say, I'm only working as a pharmacist and I will dispense medication. I don't care about anything else. However, encourage them to work, to innovate in their workplace environment, especially those who work in the field. They know a lot of things that leaders don't. So it's important for them to be involved. Respond constructively to disruptive idea and bad news. Again, it carries the same theme that new ideas are feared by the leadership. However, you have to embrace those new ideas as they come along to the leadership. When you reject feedback, you have to explain why, especially for those new ideas. You have to say, this idea is not the way we should go because of certain reasons. You don't block them completely, but you have to ensure to explain why you rejected this feedback. Weigh in last, especially for those leaders who have multidisciplinary or a lot of individuals in the team. You have to wait for yourself to get all the feedback from all the team members. And lastly, weigh in last. And model vulnerability. You have to ensure those who are don't have the confidence, again from the previous lecture, they don't have the confidence to build up their confidence and to ensure that there is no wrong idea. All of us work together to innovate in the workplace. The second toolbox or toolkit in this toolbox, which is to think inside the box. Again, the idea here is that the thinking outside the box usually require a lot of resources. However, when you think, again, it's a weird concept to think inside the box, but imagine it, and I think I heard it in one of the previous lectures, there are a lot of restrictions and constraints, especially for those who don't have a lot of resources. So constraints, again, it fosters and forces clarity and creativity, often lead to practical, scalable solutions, not those that requires a lot of budget and a lot of resources, and encouraging problem solving with very few monetary or even resources needed that match real world conditions. The last toolkit is to embrace serendipity. Again, the definition is the fact that something interesting or pleasant is happening by chance. I don't want to get in details. We know about the story about how they discovered penicillin. A serendipitous moment. Because an unexpected event happens which leads to someone seeing the value in this unexpected event, and lastly, someone will leverage or value this opportunity. Again, as a leader or even frontliners, you have to document this, and as simple as documenting what you see as unexpected, and you see the value in improving this process or workflow, document it, seek help in discovering how you can improve or innovate in this aspect. Those serendipitous moments are few, but it happens in our workplace, and I think it's the most important toolkit to embrace among all the previous toolkit. So I will leave you with this ways to start. It's a quick ways that we can start in your workplace to start to innovate in your workplace environment. Set innovation meetings. I know we all, especially those who work in hospitals, we have a lot of meetings that focuses on KPIs and very rigid meetings, but we try to introduce innovation meetings, especially those who are done monthly or even quarterly, to ensure those who innovate are coming together and try to think about your work differently. Arrange visit to take it, especially for those non-healthcare settings. You will never know where you will find ideas or opportunities that you can implement outside the healthcare field to implement into the healthcare field. I know a lot of fields are already very advanced, and to try to collaborate with them, either technology-based or even administrative-based, would help the healthcare field tremendously. Introduce short, playful activities in your office. Design physical spaces that encourage collaboration. Those open or closed desk places are hindering innovation. Open physical places are the way to go. Set up fun retreat days to foster communication between all the teams. Incorporate playfulness strategically, because I think already institutions are implementing strategically the innovation. However, they don't introduce the idea of playfulness. As I said before, fun has to be a cornerstone when you try to innovate in your workplace. Foster cross-disciplinary interaction, and lastly, making experimentation a daily habit or a weekly habit in your workplace to ensure that it's an integral part of your culture. That's it. Thank you so much for your attention, and I hope if you have any question, you can ask me in this. Thank you so much.
Dr. Sam, if you can join me for a Q&A session. Do you have any questions from the audience to any of our speakers, Dr. Osama or Dr. Fahad? Okay, we have a question with Dr. Muhammad.
Thank you, Dr. Osama and Dr. Fahad, for these great presentations. I have a question. Can we put, or is there any kind of KPIs that you can really put on the leaders or on the managers to ensure that they are following the proper way of improving the environment and the culture in their area, and to ensure that they are escaping from being a toxic? I don't know what kind of KPI you can do. Is it a 360 evaluation? Is to ask their employees about their performance? But we are putting, as Dr. Fahad, maybe he mentioned in the last slide, that we are putting a KPI on every pharmacist in our area. How can we, or is there any KPI that we can put on the leaders to follow up with them, that to ensure that they are really creating this culture for their employees, for their staff? This is my question.
Well, before I give you the stage, it came to my idea now, during the performance evaluation, why do we don't put a criteria that, every employee should at least raise 2 innovative ideas, for example, to be discussed for per year, and or each employee has to implement or lead a project related to innovation, for example. This is doable, wallah. Something that can be measurable in order to assess a performance for an employee. What do you think, Dr. Na?
Oh, thank you, Dr. Thank you, Dr. Mohammed, for the Thank you, Dr. Mohammed, for the question. And I think Dr. Osama mentioned it clearly. And even he embraces serendipity when I think he thought about how would you can implement some sort of KPI for it. To answer the question, I think it's to focus on the process, not the end goal, because innovation usually it's not a measurable element. So you cannot measure, for example, you need a specific number of innovation. However, you need to focus on the process to ensure that this process is ongoing. Innovation will come eventually, be it in a few months, even in years. Innovation will come. You have to focus on the process to ensure this process is followed continuously and try to improve the process, not to focus on the end goal. Thank you.
يعني كمان speaking about imposter or engagement or satisfaction, you know, it's nice, Dr. Muhammad, to set a culture in the institution where you can set, for example, a monthly theme in your department to speak about, you know, imposter syndrome, to speak about are you happy at work, to speak are you engaged at work, and addressing these issues on a daily basis during your huddle, during your quick meetings, every day for 1 month, set a clear culture actually. So also monitor your employee and, you know, measure how many pharmacists speak up. You know, this is measurement. How many pharmacists come to you and, you know, raise an issue in the department? You know, how many pharmacists came to you and say, I'm not really self-confident? All these can be measured, and it's very healthy. We call it, we used to do it at Cleveland Clinic under a big theme, it's okay not to be okay, culture. So you are unhappy, it's okay not to be okay. So keep spreading this phrase or this statement in your department, and it really has a huge impact.
Well, thank you, Dr. Mohammed, for the question. I think it's really excellent because I was going to touch base on a similar thing. When we talk about innovation, one of the most important things is innovation culture. So you creating a culture of innovation enablement. Transferring it to being a KPI as a quantitative thing, it might be a challenge, but I agree with you, it has to be targeted innovation. So it's not for the sake of just innovating. Are we doing something that really has an impact? And the word impact is the real difference between innovation and creativity. Innovation is something that you do, but it has an impact. But I think it's something that we really need to stress and have it in our daily work as leaders. My question is to Dr. Osama. So you mentioned about the imposter syndrome, how you can do it. You shared very nice scenarios. In each one, you give example of a mentor. So the mentor would do 1, 2, and 3. My question is a little bit higher level. Not everyone have access to good mentors.
Exactly.
How can you reach a mentor? So some of them, they have this practice of mentorship program in the workplace or the program, but not all of them. If I don't have one, I don't have a mentor, how can I reach someone? Is it appropriate to ask for mentorship? What will be your guidance?
You know, again, people misuse the term mentorship. Mentorship is not something, خلاص, I have a mentor and I go. You know, mentorship is a program. It has to be lobbied with the HR department. Mentorship should be structured. You should have a matching criteria between the mentor and mentee. And, you know, you put KPI on certain times, how many minutes per week, for example, you meet with the mentor, etc. And this is what drove us to establish the IVPN network, actually. IVPN network is about guidance and mentorship. We created listservs in order for the pharmacist to be surrounded by subject matter expert and allow easy access to the mentor. We haven't done, actually, like you did in the university, a matching program, But it's really working when somebody come to me and tell me, Osama, you know, I need to speak to someone in this particular matter, so I link him to them, etc. So yes, it's not easy to find a mentor, but it is doable. Yani, if you work hard, you can really access those people.
Definitely, I totally agree. Sometimes you need some courage to go and reach to someone.
Yeah.
Last question, and then we can wrap up the session to Dr. Fahad. So you were speaking about innovation in a workplace. My question is, from your experience of what you've seen or read, what would be easy steps for organizations to open the innovation door to their employees? Would be like a small hackathon, would be a competition in the pharmacy, would be like a hospital-based innovation supported by the leaders. What ideas do you have?
Yeah, thank you, Dr. Ahmed, for the excellent question. I think some of them I mentioned in the last slide, but again, to reiterate, and I think your examples are very concise and good to implement. Again, it depends on the institution. From my experience, try to see how the employees are engaging with you. Usually the employees or frontliners, they have different types of engagement. Some of them needs to be in meetings and official meetings and try to document as much as you can. Some of them, they prefer hackathons and competitions, as you said. It depends on the team and the team dynamic and how you try to engage them. The most important word here is to engage them. As long as they are engaged, you can accomplish or achieve the level of innovation that you need. Again, they have to be engaged.
Well, thanks so much, Dr. Fahad. I'm just going to close it with a small word to the leaders. One, when it comes to innovation, the strength of innovation comes from top-bottom approach. So you need to be, as a leader, pushing people to get it done, regardless how much innovators you have. If they are not enabled and protected, you're not going to have an outcome. Thank you so much for your time. Thank you so much for our speakers. And we're going to move to the next session. Thank you.
Thank you very much.
I'd like to thank Dr. Ahmed Demirdash and special thanks to all the speakers. Thank you for sharing your wonderful expertise. And now I'd like to invite Dr. Mohammed Al-Shinnawi for honoring the respected doctors in the previous session. First, with the session moderator, Dr. Ahmed Demirdash. دكتور أسامة طبارة. دكتور فهد الخزاعي. And now we will move to the next session.
Ladies and gentlemen, distinguished guests, and respected colleagues, my name is Safar Al-Ghamdin, an intern doctor of pharmacy at King Khalid University, and I will be introducing this session. This session focuses on how pharmacy services can translate performance insight into measurable financial and operational impact through effective strategy, governance, and KPI management. The session includes the following speakers and topics. The first topic will be with Dr. Lina, establishing a sustainable clinical pharmacy department, strategies for achieving positive financial outcomes. The second topic will be with Dr. Nabil Khammas, Dr. Anas Hamad, and Dr. Abdurrahman Al-Anizi about beyond numbers, mastering KPI management to elevate pharmacy services. This session will be chaired by Dr. Ishtiaq Bajnaid. Dr. Bajnaid is a consultant clinical pharmacist specializing in oncology, hematology, and bone marrow transplantation, and currently serves as a head of the clinical pharmacy department at King Abdullah Medical City in Mecca. She is also an oncology specialty residency program director and has completed her PGY1 pharmacy residency training in the United States, followed by her R3 training at King Abdulaziz Medical City, National Guard Health Affair in Riyadh. Dr. Bajnaid is an effective member of the Saudi Oncology Pharmacy Society and contribute to several institutional and national professional committees. Dr. Ishtiaq, the session is now yours.
Good afternoon, everybody. I'm Ishtiaq Bajnaid, and I'm very honored to be part of this conference and to moderate this session. Our first session is a lecture about establishing a sustainable clinical pharmacy department, strategies for achieving positive financial outcome, and it's actually one of the topics that I want to attend personally. It will be presented by our distinguished speaker, Dr. Lina. Dr. Lina is the head of clinical pharmacy services and senior oncology hematology clinical pharmacist at Adult Oncology Unit, Tuam Hospital in UAE. She's also an adjunct assistant professor at the Faculty of Medicine and Health Science in United Arab Emirates University. She's also a residency program site director at Tuam Hospital. She had her master's degree in clinical pharmacy from UCL, the School of Pharmacy in UK, and she has many publications, and she's participating in many clinical trials, phase 2 and 3 clinical trials. Please welcome with me Dr. Alina.
Assalamu alaikum. It's very, very nice to be with you here. I'm honored and really, I'm privileged to be with you today on the land of Saudi Arabia. It's kind of a place that you would love to be in. Maybe you would love to live all of your life here. I usually envy the people who live in the holy cities of Saudi Arabia. MashaAllah. Wish you all the best, and إن شاء الله هاي البلد دائما تكون عامرة بأهلها بتقدم دائم إن شاء الله. So I'm also privileged to talk about this topic, and I believe that many of people in this hall really believed in it. I would like to share my experience, and I would like to learn from you in the question and answer session. But I think this is something I'm going to talk about, something that we all do. Maybe we don't call it sustainable clinical pathway, but something we all, and I'm going to something all of us are doing in our practice, and I'm just going to point at it and share with you my little experience in this. All right, so let's start with the agenda. So I'll just give just a touch on the background about health expenditure and why we're talking about sustainability. The major part of this presentation will be focusing on clinical pharmacy strategies for achieving positive financial outcomes. Of course, we're going to list some challenges and mitigations, and finally, we'll set together some conclusion and recommended future recommendations. So what we're talking about, and I believe that you have heard a lot about how much we spent on health care. According to the World Economic Forum, in the year 2021, a global spending on health reaches a staggering number. It's $10 trillion, accounting for around 10% of our global GDP. Long-term projections suggest that this figure will go and extend up to 18 trillions by the year 2040. The increasing healthcare expenses are becoming unsustainable, and that's by the World Economic Forum, not my own words or your own words. And yet, which was a little bit surprising to know, according to the World Economic Forum, over the last decade, the life expectancy has stagnated in many countries, including the US. So we know that because that was a little bit, for me, weird to hear that life expectancy is not improving. Of course, it was improving over the last decade, and I believe that in Saudi Arabia, you have very good numbers of extending the life expectancy in the general population and also in other Gulf countries. But apparently, according to the World Economic Forum, this number has not been interestingly increasing in the last decade for some countries. Okay, we spend a lot, and according to the GDP, we're spending a lot, as I mentioned in the previous slide, around 10% globally. Of course, there is a trend of increase over time, over the years, and this is not seen only in high-income countries, but also seen in low and middle-income countries. According to also the world data here, we are spending a lot, and if we want to look about our region, we are we're not the highest, apparently, as you can see in the slide in front of you, maybe the States and, the United States are spending the highest, but also we are one of the countries who are spending a lot. That's why we need to talk about the spending. And as pharmacists would like to know, that actually the number was for the total health expenditure. But what about medications? Apparently, the total drug spending average is 15% of healthcare expenditure in the year 2022, and the most recent year consistently available for the 12 major global countries studied, ranging between 9 and 20%. So we're spending a lot on medications. So we're spending a lot on healthcare in general, we're spending a lot on medications, and we're spending a lot of our budget. So this is the topic, that's why we're here to talk about it. And everyone is talking about, it's not just us, it's not just the pharmacists, everyone is talking about how we can sustain, the health expenditure and how we can deliver the best care to our patients. So if I want to say this is the ideal situation in front of you, we want what? We want sustained clinical impact, we want efficient use of resources, aligned with our institutional strategies, and of course, we want a solution that there is a capacity of growth in it. Okay. Why we're talking about the pharmacist role? Because we are actually sitting at the intersection of a clinical decision making. We are wise people. Actually, I like the word financial wisdom, meaning just spending less. So when your parents tell you have to be wise in spending, this means they don't mean, of course, increasing, they're meaning reduction. So financial wisdom, meaning optimizing, reducing, decreasing, whatever word you would like to use, but in the same time, with the primary objective of delivering excellent healthcare service to the patients. This is something we should focus on. And I believe that we all go to hospitals to help our patients, make them survive better with a good quality of life, and we hope that we're not spending a lot. But it's not hope only. We need to build a strategy to do this. Okay, so maybe this slide talks about what I'm going to talk about in the coming 15 minutes or so. So there are two ways, actually. It's either you reduce the cost by the word expression, you use it, cost avoidance, cost reduction, cost saving, cost optimization. So we're already putting the service, but we try to minimize how much we spend on it. And on the right side, it's more controversial. We want to get some revenue as pharmacists. And this is something we're discussing yesterday with Ahmed Al-Jadia, Dr. Shinawi, and the team, about how pharmacists can get more, some of these services are built and having revenue. So maybe this is the major slide of my presentation. Now I'll be sharing with you over the coming 10 minutes what we have done and what we're doing to decrease or to optimize or to reduce, the money we're spending on healthcare. Okay, so because I came from oncology background and it's high impact service, I'm very proud to say about, how much we saved when you introduce biosimilars. And of course, there's the first line here when we're talking about biosimilars in oncology, and we're not just talking about chemotherapeutic or targeted therapy, of course, biological agents like trastuzumab, bevacizumab, rituximab. Rituximab, we were able actually to do complete switch, and we reached a point that we deleted actually the innovator. Okay, what about supportive care? Dr. Anas from Hamad Medical City, he shared a very impressive data about the cost saving when you use the supportive care in oncology when you introduce biosimilars, all right? And we were actually very successful in non-oncology when we were able to complete a switch of some items. We did auto switch even at the pharmacy level, and we did complete a switch of anticoagulants. One of the agents that we used, we deleted the innovator, introduced the biosimilars, and that was supported by the CMO. Like we sent circular to people, to all physicians, we're going to auto switch, anticoagulant, of course, after we did the whole review at the PTC. A bit more difficult than the biosimilar is the generic introduction. With biosimilar, it's easier for us. Why? Because I depend on EMEA approval, FDA approval. I have phase 3 clinical trial. So it's very easy for me as a pharmacist to come and review and put the biosimilar, guidelines and khalas implement it. But when it comes to generic, we look about the GMP of the manufacturer side, we look about the equivalence study, which is not available for IV medications. And we don't know history about using of these, this manufacturer. With the biosimilars, we deal with very high level kind of pharmaceutical factors of manufacturer. But you need to have institutional guidelines. That's why I put importance of institutional alignment. So what we did at Saha PTC, Saha is the largest healthcare provider in the Emirate of Abu Dhabi. We sat together and we created our guidelines for use of biosimilars, which was easier to set, and also about generic introduction. So we did this and we saved a lot during this time. What about prior authorization streamlining? You would think that the clinical pharmacist is not the one who's really sending to the insurance, but our role is very important because if you work in a setting that you use guidelines, you use pathway, you'll be able to justify why you're using this. So at many level, we're sitting with our financial coders and helping them to resubmit and get the approval. So pre-authorization is very important, specifically for the workflow of our busy infusion center, because you don't want to delay patients. You need to make sure that you have pre-authorization for every single item, specifically the high expensive item, before you give the treatment so that you avoid the loss. And of course, diversity service offerings. We learned, and I learned this from Dr. Muhammad Maguri yesterday when he was talking about having the finance pharmacy committee. It's very important. We never had this committee, but I know that we have worked a lot all the time together. For example, moving the services from inpatient to outpatient is high revenue. How come we didn't know as pharmacists that whenever we give medication in the inpatient, sometimes we're losing it really the money because it's much higher than DRG. So we have to move all of this inpatient protocols from inpatient to outpatient. And our role as a clinical pharmacist was very important because there were some medications we used for ages to give them an inpatient because they need the pre-medication, post-medication, pre-hydration, after hydration. And with that, we built our protocols, of course, evidence-based, and we moved most of our patients to the outpatient setting to enhance revenue. Here, we avoid the loss in cost. All right, this is something I'm sure most of you are doing in your practices, dose rounding, dose banding. You cannot imagine how much we could save when we do dose rounding for high expensive items, like specifically oncology drugs. On the right side of this screen, you could see how much we're able to save from items like protein-bound paclitaxel, abraxane, pemetrexed. This is now we're calling them conventional chemotherapy. We're saving a lot, and we used to save a lot. But how much? Imagine how much we're saving when you were doing the dose rounding within 10% according to the HOPA guidelines. It's a lot. And here I was fascinated with this result coming from my clinic here about automated dose rounding can save tens of millions in cancer drug costs. I was fascinated. Why? Because apparently they improved their system to have this automated dose rounding According to what? Not according to 5 or 10%, no, according to nearest vial size, which is something in our practice so far we do it manual. But I want to go back and to our HIS team and tell them how we can automate this so that the system will understand that we are reaching, doesn't have that pharmacy would memorize or have something to look at. No, the system will help identify that, you know, for example, let's say trastuzumab, the dose, usually the vial is 420 or 440 for Herceptin, but let's say it's 430. Imagine that you're opening a new vial for less than, I don't know, 1% of the total dose. So the system will remind you, you save the vial, and you decrease the expenditure on this patient without affecting anything clinically. All right, IV2PO, who's doing this? All of us are doing IV2PO. But maybe my point here is that to help your pharmacy team doing this, you need to have to create some kind of policy or guidelines. Create a policy helping your inpatient team. So by the way, here, of course, I'm coming from clinical pharmacy background, so I talked a lot about clinical pharmacy, but this is not really separated from the inpatient pharmacist in the operation. You help them, we're one team, work together. We create maybe the guidance, and they will help us also, not just the clinical pharmacist's job, it's also the pharmacist's job to identify patients who are stable enough to move from IV to PO. According to bioequivalence data, like, one of the major problems we're facing a lot about the IV paracetamol when you want to switch to oral. I don't know if many people of you working with oncology patients or even any patient in pain, they swear that IV paracetamol is as effective as morphine. I cannot believe, but this is something what they feel. But we explain to them that the IV paracetamol is as equivalent as the oral. So why not we move to oral? Why we're using the IV access? Why not really to use the oral? So these things that we are a clinical pharmacist, we need to set guidance, and all the team can work on it. And here, apparently, the data is diverse. You could see studies telling that they are saving around $21K, and other studies were able to save around $450,000. Maybe that depends on the drug they're using, but in general, IV2PA can save a lot without at all affecting the clinical efficacy of the drug you're giving. Also, there were some data published in the UAE about the cost saving from the Gulf Medical University. What about antimicrobial stewardship? And be honest with me, I want to be honest. All the time, I know that ASP is very important. Why? Because it's part of the GCA. So all hospitals, they have the ASP program at their facilities. And all the time I use, and maybe Abel can tell me, we're looking at the resistance. Like we want to decrease the resistance, we want to use, the first line, not necessarily broad spectrum antibiotics. And we want to make sure that we're delivering the best care to the patient. I never thought about the financial impact of having ASP till I see this data. When you build in your system a clinical intervention called ASP, antimicrobial stewardship, and you, with the support of the finance, tell exactly how much you could save. At the end of the quarter, you'll be able to see how many interventions you did, how many interventions your team did, not you personally, and then how much you were able to save. And when you run the report, believe me, we need to share this with our leadership, but I will be talking about at the end of this presentation. Sorry. So, ASP is very important to be there, not just for a clinical value, also for economical value. And this is something sustainable, and you need to continue doing it. All right, and here this review, I can share with you about the overall cost saving. This is a study done in the States, and they were talking about how much they were able to save. So actually, this is a systemic review of many studies done in the US, yes, and they were able to identify 24 studies. Only 44%, they quantified the effectiveness of the intervention in terms of overall cost saving, and cost reductions in the remaining studies range from 3 to 50%. Outpatient services for parenteral therapy have been presented and showed significant cost reduction. You're all aware about OPAT, and OPAT is really the outpatient parenteral therapy. And many big institutions, they already created this clinic where they receive referral from patients or from physicians in the inpatient, because you don't want to keep your patient in the inpatient for a long time, so you want to switch them to outpatient. How you do this? You need to have the pharmacy support, you need to have the ID support, you need to have the clinical pharmacy support. How is that? Because if you don't know the stability data, from the inpatient team and they're not able to prepare it, you will not be able to send patient home. So we receive lots of calls from ID physicians about, please tell us about the stability of this drug. We want to discharge patients and we want to make sure that the patient is coming maybe on daily basis. So we need to arrange with the case managers about it. Or if we can send the patient on pump. So you need to have the biomedical engineer there, because some of the drugs we can send it home for 7 days. Like we prepare it, program the pump, that to be infused over 7 days. The only obstacle, not all antibiotics or antifungal, antimicrobial agents are stable for 7 days. So we try our best either to switch them to IV in a way that they can come to clinic or to the ED visit, or if there is home care nurse, home care services, that you can discharge the patient on. But this is something keep in your mind. It's not easy. There is no one solution for it. But at least look at it, look at your policies, look at your setting, and see how you can switch patient from the inpatient to the outpatient, so that you can decrease what? The bed time, the inpatient bed time, because it costs a lot. Okay, maybe this is something new, not new for everyone, but something new in our practice. We want to do it. This is not the future, you can say current future. The penicillin delabeling. We're all aware about the penicillin allergy, the pseudo-like allergy, because we don't know. The patient comes, say, 20 years ago, I had some rash, and we label them as penicillin allergy. And then later on, if this patient is having, severe infection, we will not be able to give penicillin in the first line setting. So we go to broader spectrum and be more expensive item. And this is something recognized in healthcare. And so what we can do, actually, luckily, we start to have more of what you call them allergist specialists. So we have in our hospital and also other hospitals, sister hospitals and Saha, they have allergists. Now they feel the need for having allergists in their system. And we started looking at the penicillin delabeling. We need to create policy about it and to refer patients that we're suspecting that maybe they have mild allergy to this specialist who will do evaluation and they will do the testing. Some people, they don't believe in testing, they believe in oral challenge. So there are different areas. Bottom line, we want to identify patient system that we're not sure that they have anaphylaxis or severe kind of allergic reaction. We refer them to this immunologist and allergist services. They will do the testing, they will introduce the drug, and maybe they can do the sensitization. But apparently, this project will lead to lower pharmacy expenditure, fewer adverse effects, and better antimicrobial stewardship compliance. So that's something that we are hoping that to see results from it. What about formulary and non-formulary management? I think you have heard a lot about it from our colleagues, and I'm referring to Dr. Anas again, that he also published some data about the non-formulary, like items where you were able to save. When you reject, you're able to save. I'm sharing with you here one example that I'm doing it recently. And I'm not claiming I'm the expert in this, but I am PTC coordinator. So I receive lots of non-formularies. Some of these non-formularies, I can claim that I'm okay in reviewing it, but I start to receive lately this kind of a new class called complement inhibitors. Agents like iptacopan, avacopan, bixetcoplan. I look about the cost of it. If you look at the cost in the UAE, it was ranging from 1.5 million to 2.5 million per year for diseases that we never knew that complement inhibitors or these targeted therapy are working, or like a new therapy, innovative treatment are working. So we have diseases like IgA nephropathy or glomerulonephritis, where you used to treat them with steroids and some of the immunosuppressant. But I never thought at some point we're going to, whenever I approve any request, that I'm going to cost the hospital 2 million dirham. So what we did, I spoke with our, in the PTC, and we agreed to create task force. Task force, we have the support from rheumatologists, nephrologists, clinical pharmacy services. Why we did this? Because this kind, if you go and review literature, you will not see very strict kind of guidance. It tells you, you can use this. If it doesn't work, you can use this. And the criteria for implementing this is not that easy. And maybe I need to run a report by next year to see how much I rejected, how much we saved the hospital. About aging, for the sake of time, you're all aware about aging processes. These category of patients, they consume a lot of budget. They are in polypharmacy. Please start talking about deprescribing in your facility. This, it shouldn't be according to our wish or the way we clinically see these, de-prescribing. Do it as policy and help your team identify which patients or which agent that we can de-prescribe easily. You can start with something like PPI. You can start with something like hypoglycemic agent. You will see many on the patient, and the patient doesn't need them. You could antipsychotic, anxiolytic, and so on. But of course, you don't do this alone. You're not going to DC. You need to work with your team about it. And there is one idea is that if we could create some kind of collaborative agreement or collaborative like kind of a clinic about polypharmacy. But here I just want to share with you about the stop frail, like it was a European study where a pharmacist-led intervention using the stop frail criteria in nursing home residents found that they were able to save 2,700,000 of euros in direct saving from medication prescribed, and they were able to show the evidence that they were able to save 61,000 euros in cost of avoidance of development of adverse event. So we are talking about something that we've been all doing. We need to know how much we're saving. Maybe we're doing, but we'll not look at it. This is one of the things I learned from, while I was preparing this slides. We oral clinical pharmacists are involved in adverse event management, or specifically when we're talking about the adverse reaction management. In oncology, I receive many reports about infusion reactions. Okay, we do a lot. We modify the pre-medications. We give them, or we created the order sets for pre-medication, and we created actually the order sets for the management of infusion reaction. And we make this order as a standing. So I don't know, 10 years ago when you used to have infusion reaction, the nurses were panicking, please call the doctor, want him to assess, start the medication, and so on. Now they don't do this anymore. They are trained how to deal with it. There is a standing order they can activate because it's already signed by the physician. So they will activate and start according to criteria base. How much we're saving by first avoiding, by preventing this when you optimize your pre-medications, and now we're working with very high risk account of agents. If we don't really make the pre-medications like mandatory within certain time, most of our patients will be reacting. So we're saving by preventing the adverse events, and we're saving by utilizing properly resources. So in every area now in our hospital, there is what you call it hypersensitivity kit. They don't have to call to bring the medication. It's there. They're trained how to use it, and that saved lots of time. And we learn about it once we have incidents about a patient that had very bad reaction in the inpatient setting. It took a long time for the physician to come and assess, and the patient ended up in the ICU. This is something that we reported, and it was very easy, to create a hypersensitivity kit there, order a standing order. The nurse don't have to call 7 times to call the on-call. They can start it immediately according to our, agreed policy. Don't quote me, this is recorded session now. All right, now the more controversial part of the presentation, revenue-enabled services. Here, I'm taking my data from the published data from the US, but I will share with you our experience in the UAE as well. So focus on high-value billable services such as preventive care, like annual wellness visits and vaccination. I think, I'm not sure in Saudi, but in the UAE, pharmacists are licensed to do vaccination. Is it widely implemented? I'm not sure, I cannot tell you. Like in my setting, it's not yet still nurses, physician order, nurses administer vaccination. But the pharmacists and big community pharmacists, they are allowed really to administer the vaccine. But they don't have, they don't have code for billing the service itself. They're just getting the money of or the price of the vaccine only. What about collaborative physician-pharmacist visits during using appropriate A&M codes? And there was one study talking about blending these services, maximize revenue, and generate positive return on investment as demonstrated by the PRIME. So what's the PRIME? The PRIME is actually a study called the Pharmacist Revenue and Integration Modeling. They call it the PRIME, and they want to implement this. Where is it? It was in Memphis, Tennessee, where they have created a novel tool to support financial decision-making for pharmacy integration. The objectives were developing PRIME, exploring implementation, and modeling financial viability. But they're able to show that the most successful model was printed preventive and collaborative service, where they were able to generate 200,000 in annual revenue and net surplus of around 100,000 return on investment. That's a big thing. That led, in that setting, to establish clinic academic partnership, placing 2 pharmacists with all of 1 FTE in the clinic because they showed to their management they were able to save. Now, of course, you're all about the collaborative physician-pharmacist visits, where the ACCP give us and help us to know how we can build this collaborative agreement. And our colleagues in Qatar, they have this collaborative agreement, and Hamad, and also in Abu Dhabi, we have some services that we have collaborative physician-pharmacist agreement, where the goal of this kind of agreement is to improve clinical outcomes and safety, reduce adverse drug reactions and polypharmacy, and create financially sustainable clinical pharma services. Why we're not doing this in our countries? Because we don't have, as Dr. Jidea mentioned yesterday, we have maybe the prescribing privilege in some countries, but we're not really classified as a provider. So you cannot bill it under your name because you cannot even start encounter, what you call it, the encounter. It cannot be under pharmacy name. It should be under physician name. What we do, we run the clinic with them, we do prescribe under their name, but we're not getting the money paid back. The good thing I can share with you is that, of course, it depends on the country's regulation. So we don't like practice in silos. We have the insurance companies are reimbursing us. What we did in the Emirate of Abu Dhabi, we're communicating with the biggest health insurance. I don't know if you heard about Daman. And with Daman, we created our proposal for certain high specialty clinics, like HIV, heart failure, cystic fibrosis, and recently oncology. One of the most recent one was oncology. At that time, we showed them what the pharmacist will be doing, and they agreed with us that we can use the CPT code for education. So what we did, they refused actually to use it for MTM, the medication therapy management, but we were able to do it for education service. So we're getting paid for education services, not by all clinical pharmacists, by certain people who are working in these specialty clinics. So that we considered at that time we're so proud about it. And we were able actually also to reimburse for INR clinic. But whenever we use the term MTM, they refuse. So we're not using it. We're using another CPT codes that agreed by them that we can utilize for certain services we're doing in the clinic. All right, maybe later we can talk about, like what you're doing here in the UAE and the Saudi Arabia. And even I thought, today I had a discussion with one of our colleagues coming from the States. I thought that it's very easy for them to bill for their services. Apparently it's not. Apparently because you're working in diverse kind of health care system, not all insurance companies are really paying back to them, even if they are doing very high specialized clinic like NTM and so on. So apparently it's a global issue, but if we're able to put efforts together, maybe at some point we'll be able to bill our services as clinical pharmacists. Okay, so when you're doing strategies, you need to have clear vision and mission. You need to have governance and leadership structure, define your clinical roles, and do it within multidisciplinary integration. I'm so sorry. Okay, so documentations. I don't know if you're attending the session yesterday. Dr. Shinawi was, I hope that he will be with us today, but he was talking about, the clinical pharmacists are not doing properly documentation. When we start our initiative about following the clinical intervention report, we found this. Not all clinical pharmacists are documenting. Not all of them have consistent documentation, because documentation is very important where you can run the reports and avoid, the cost. I have a minute or we're done? We're done, okay. So just remember one thing. We're not working in silos. We're not just the clinical expert. We need to work with our teams, the informatics. They helped us a lot, really, improving our clinical intervention form. So every time we do something, we test it, and then we could improve it. We did a lot in the ASP, like, ad hoc form, or we're reporting intervention, and so on. Order sets were embedded in our protocols, so that it helped a lot. Okay, so if you want to talk about the challenges and mitigation, budget and staffing constraints, of course, I'm talking about clinical pharmacists, but do we have position for a clinical pharmacist? But I think that this is kind of a challenge that we could turn it into opportunity. Run the reports, show the work, the evidence that what you're doing, go to speak to your leadership, because you need their support in staffing and also maybe in directing you in different pathways. Some people are resistant to change. You need to do educational sessions and have MTT collaboration, documentation gaps. We talked about it. We make our form easier and friendly to like a clinical pharmacist. So it's a continuous process. There is no end for it. Okay. about the sustainability, it's very important to integrate with team-based care and align with organizational priorities. متأسفة. Why is that? Because some people, maybe I'm clinical oncology, I think, the oncology is the best services ever, we're going to save a lot, but maybe this doesn't match with our organization priorities. So we need to accept each other. We need to share our proposal to the leadership of the hospital, agree on something, and then work on it and implement and monitor, record and monitor. Okay, I think that's the future is about integrating virtual pharmacy. I'm not sure if we'll be able to do it soon, but we can do it as telemedicine, but we're not able to be billed for it. Pharmacogenomics, something now is booming. We're talking about how much we could save by implementing the pharmacogenomic rules, advance the clinical role of clinical pharmacists, and value-based integration. And finally, this is the last slide. So, conclusion from cost center to values generator. We are in ideal position as a clinical pharmacy/pharmacy to build our strategies that will help and lead to cost saving. In the coming session, you'll be talking about the clinical KPIs, maybe financial KPIs. We need to talk about documentation, very important, financial reports, creating monitors so it will be easy for you to analyze later on, and leadership reporting so that you can get the support from them. With that, I would like to conclude my presentation. I would like to thank you, and I'm sorry if I took more time.
Thank you, Dr. Elinia. It was very interesting, very comprehensive. I wouldn't do the same job if I was in your place. It was very helpful. So just a few minutes, we will do a camera gifts to intrigue the audience into more attendance. So please start. Please come to collect your gift. Thank you for your attendance. Well, now we will go to our next session. I am very delighted to introduce my next speakers, Dr. Abdulrahman, Dr. Anas, Dr. Nabi. Please, can you join me to the stage? So Dr. Nabil Khammas, he has earned his bachelor degree in pharmacy from King Saud University in Riyadh, in Saudi Arabia, and Doctor of Pharmacy degree in Campbell University in USA. He's a board-certified pharmacopharmacy specialist and Director of Pharmacy Affairs Administration at King Fahd Specialist Hospital, Dammam. Dr. Anas Hamad is the Director of Pharmacy Department at Qatar's National Center for Cancer Care and Research. He's the Head of Medication Safety and Quality Center and Head of Pharmacy Research Center at Hamad Medical Corporation Pharmacy Executive Office. He holds the position at Qatar University as a clinical assistant professor of clinical pharmacy and practice. He's chairing the standing committee on medication services at Qatar Red Crescent Society. He's leading the Health Technology Assessment and Innovation Regulation Project under the National Health Strategy in the Ministry of Public Health. He's also the Vice President and Director of ASPR Qatar Regional Chapter. In addition, he's the Vice President of the FIP Hospital Pharmacy Section in the East Middle Eastern region. Finally, we have Dr. Abdurrahman Al-Anizi. He's a clinical pharmacy consultant at King Abdullah bin Abdulaziz University Hospital and serves as a clinical assistant professor at Prince Noura bint Abdurrahman University. He completed his ASHP accredited PGY1 in pharmacy practice and PGY2 in hematology oncology residency, and holds his master's in science and in health economics and health policy from Brunel University, London. Dr. Arnezi previously served as the head of ambulatory care pharmacy services and also leading the efforts to developing the pharmacist-led clinics there. Please welcome my panelists. Dr. Elena, can you join us, please, so we can have a discussion about KPIs in general? Thank you. Hi. So first, I would like to talk about, of course, this is the most important thing when you are talking about leadership and administration in pharmacy, the KPIs, what we are looking for, how we are working, is everything fine or not? So I would like to ask Dr. Hamad, Dr. Anas, sorry, what KPIs should a pharmacy leader or a pharmacy manager put in place to make sure, I know it's a very broad general question, but we will start with this. What kind of KPIs, let's say I was appointed today as a director of pharmacy, what should I do in terms of KPIs? How can I know that I'm doing right or not?
Thank you very much, Doctora. It's a great pleasure to be here. And thanks to the Dr. Shinawi and everyone for the kind invitation. So, this is a huge topic. We can talk until tomorrow about it. But in a nutshell, so as a pharmacy department, of course, and any healthcare services department, you have to set key performance indicators that always should, first thing that you should keep in mind that they should be aligned with your department objectives and goals. So, of course, in pharmacy, we serve patients and we look for patient outcomes. So, you need to set, by nature, KPIs as a word is something that is quantifiable and measurable. So, we need to be realistic. This is number one. And we need to put these KPIs in different aspects. Yes, our ultimate goal is patient outcomes. So we need to have KPIs that are about health and health outcomes in terms of the factors that in our work would impact patient outcomes. Something like medication errors, something like accuracy in IV preparations, or et cetera. But also there are some other KPIs that, although they are not directly impacting patient outcomes, they are very important to measure because they will reflect on the patient experience in the hospital generally. Something like some operational outcomes, such as, for example, waiting time in the outpatient pharmacy, or time to prepare new chemotherapy preparation until it reaches the patient. Because this will impact patient satisfaction, which is something we should always keep in mind when we set our KPIs. And the final one is about patient satisfaction directly. So measuring patient satisfaction and having a standard KPI to measure this through whatever. We can maybe talk, our colleagues can talk more about this, but yeah, I would set it as clinical outcomes, operational outcomes, and patient related, directly patient related or patient satisfaction outcomes. Yeah.
Okay, fine, nice, fine. So let me, can you please, coordinator, can you give me a moving mic عشان سوري بس عشان الباناليست يكون الدسكشن أفضل. Yes. Yes.
طبعا I second what Dr. Anas said. It's a very important science to establish KPIs and to choose KPIs for your department. It's not a one-size-fits-all. It's two pharmacy areas. If you have like an inpatient pharmacy and an outpatient pharmacy, or if you even have two outpatient pharmacies in the hospital, they may have different KPIs. Yes. It's not something you choose for all. The best thing is, my advice for administrators, first of all, is to have a person who is specialized in quality systems, because they are experts in looking at where everything is not going as it should be. Look at your value drivers, for example. The value drivers, in definition, are the factors that play a key role in determining your worth, in improving your worth, your value. It's what drives customers to come to you. Value drivers are, what actually initiates the process of KPI. So you identify what your value drivers are. It could be patient satisfaction. It could be financial. There are financial value drivers and non-financial value drivers. And when you choose your value drivers, the next step is to choose your objectives for these value drivers. So each value driver may have one or more objectives. And then from those objectives, you determine your KPIs. So your goal, the goal is the what in your process. So what you're trying to achieve. The KPIs are the how. The objectives, are the how. So how you achieve your goal. And the KPIs are if you look at it's like if you're driving a car, the KPIs are like your temperature gauge, your fuel gauge. It's what you monitor. So the KPIs are measurable. Goals and value drivers are not measurable. You can't measure them, but they tell you where you want to go. The KPIs are what you monitor as you're going. So are you doing well? Are you not? It's very complex, but people who are expert in this are very valuable. That's why quality pharmacists are essential. Now, it's a very important specialty to have on your team.
Sure, I agree. So talking about the value drivers, now I understand that each hospital or each institution, healthcare institution, whether it's hospital or something else, they usually have a strategic plan. And this is a major issue for us, or not an issue, a major component of driving KPIs and putting where the value. So some of the leaders, I would say, of the pharmacy, they don't have a clear vision of the alignment or even the strategies coming from up. And putting strategy of their own that's aligned with the strategies of their institution, and then putting the KPIs. My question is, do you think that the pharmacy should have all their values, value drive, or KPIs totally 100% aligned with the strategies, or they should do other things that it's naturally fixed to all pharmacies? Let's say, for example, the waiting time. I don't think there is an institution would not put customer satisfaction as a driving point. But let's say this institution, for instance, they did not do. Can we identify, for example, 3 or 4 KPIs that, regardless of the most important KPIs for pharmacies? I know it's another big question, but to start with, I would ask, what is the most common or most important 3 KPIs in your institution going in the pharmacy, you think?
For me?
Yes, each one.
I mean, like you say, if you go way up to the strategy, which is the top of the ladder, it's not very clear. You can't build your KPIs based on the strategic plan of the institution, but you have your own operational plan. Based on your operation plan, you choose your value drivers. And again, like I said, value drivers are not necessarily the same. Yes, it may be, I mean, it may be different from a hospital to another hospital with the same settings. For example, it depends on what I lack. For example, if I have an issue with waiting time, for example, my patients are waiting a lot, there are many complaints, patients are not satisfied, then I would probably choose waiting time as a main KPI. And I look at the value of the waiting time and I work on it. I put my KPIs on it and look at the processes. Have, for example, dashboards to look at how I'm doing from day to day. So maybe waiting time is a very common, KPI. I think it's universal. I think every outpatient pharmacy should include waiting time, definitely, because you want to know.
Yes.
It's a basic thing. You want to know where you're going wrong.
What about Dr. Anas? What do you think? Another KPI that it's...
Yes, so again, of course, every, as you mentioned, you can align it. If in Qatar, I didn't mention financial, مثلا, and until now we don't have insurance.
Yes.
Next year we will have insurance, so we will add financial KPIs, for example.
Yes,
so it's related to the context. بس يعني something global, I would think of the IV room, working in oncology, for example, chemotherapy preparation time. This is always a critical component that I used to receive a call from the CEO every few days about a patient complaining that he has been waiting 2-3 hours, and when you investigate, it's only 45 minutes. But anyway, so the average time. So we set this as a KPI. The time from when the order arrives to the pharmacy until the actual chemotherapy preparation is received by the patient. And this is actually, in most cancer centers, this is a KPI that is always set there. And it's important to also to show for your leadership that we are within this threshold, let's say 40-45 minutes, for example.
Yes.
And like 90% of our cases are, or 95 are within this threshold.
Yes, you can.
Assalamu alaikum. Actually, to answer the first question, aligning the KPI with the hospital vision and mission, actually I agree. The first important thing is to align our KPI with the mission of the hospital. So you can convince the leadership for the importance of the pharmacy services. We have to put this in mind always. And second thing, it was also mentioned by Dr. Anas and Dr. Nabil, regarding clinical outcome, patient-related outcome. So we are a healthcare provider. So it's important to focus on this part to have a clinical outcome. So there is a lot of KPI can be monitored, either clinical and non-clinical KPI related to patient outcome. One of them is the around time for medication delivery. And also, even for the rate of preventable ADR, it was also, I think, mentioned by Dr. Alina in the last lecture.
Yes.
It is very crucial. It has a cost saving, it is a clinical outcome, so it's an advanced pharmacy rule. So this is one of the very important KPI we have to measure and keep it in mind.
From here. Okay. So to follow up on my presentation about the clinical pharmacy, like a clinical KPIs, now we're moving from pay for service to pay for quality of service. We haven't started this yet in the UAE, but I think it's soon to be. Now in the hospital inpatient setting, we have DRG. They're not paying, the insurance is not paying us for every single medication. They are paying for the stay. So if you want to treat infection like febrile neutropenia in 5 days, or you treat the same patients for more than 10 or 15 days, then you'll be losing a lot. So now we pay for the value or for the outcome, as Doctor mentioned. And I believe that we need to get to be ready for this. Soon, they are going to pay for the breast cancer patient according to their management rather than according to the medication itself. We need to be ready for setting KPI for our practice. And I want to tell you, 20 years ago when I started my pharmacy profession, I didn't like KPIs. Why they are doing GCIA, SHP, all these kind of accreditation. I didn't believe in them because I felt that you're stressing us. But now I believe, I think this with aging and maturity. It's very important to have KPI. It's very important to monitor your practice. If I put the whole, guidelines about menstrual neutropenia, and then I don't know if my physicians and nursing and pharmacy are preparing the antibiotic and given within 1 hour, what's the purpose of these guidelines? So we need to monitor our practice. I believe medication reconciliation upon admission, transfer, and discharge is very important KPI that we have to follow. I believe that KPI, like a clinical KPIs, like management of certain, high mortality, like febrile neutropenia or sepsis, we need to monitor this. Are we really administering the drug within 1 hour or not? Because at the end, we're going to be accountable for that. The length of its stay. Now, it's something I think you work in clinical teams, and you know that the case manager has a great role, because if you don't treat your patients properly, they will stay longer. And what about the KPI of readmissions? I'm sure that you start to see this. Now we have committee for this admission and readmissions. If you have large percentage of your patients are readmitted within certain plans,
from preventable adverse reactions, for example.
Yeah, yes. and so on. So yeah, we need to be ready for this, because apparently the insurance is going to pay us according to the quality and the outcomes.
Yes. So just to talk about the health outcomes, the definition or the health outcomes, healthcare outcomes that is universally aligned or defined. It's about quality of life, safety, effectiveness, and cost, and mortality and morbidity. This is the whole, the healthcare organizations. So when we are talking about the pharmacy, which of these 5, quality of life, safety, effectiveness, cost, and morbidity and mortality, we can start right now at least focusing on? I'm sure, for example, the quality of life, I don't know if waiting time considers the quality of life, if it can be linked to something like that. Delivery, medication delivery, how much of our medications are delivered to the patients in their safety and comfort of their home. And we can link those as a quality of life, increasing the quality of life of patients. But I'm sure if we are going to talk general about pharmacies, I think most of us either talking about processes, which is the other types of KPIs, which is either input, output processes, outcome or balancing, leading KPIs, but not really talking about linking those to the outcomes. So are we aligning the outcomes and the KPIs together? And which do you think of those 5 the pharmacy can contribute most? Safety, effectiveness, cost, morbidity, mortality, and quality of life. What do you think, Dr. Khammas?
So basically,
quick win. what can we contribute to which
I think
outcome?
to every one of them.
Yes.
If you look at our processes, what we do, it affects all 5 outcomes. Quality of life, especially when you talk about hard outcomes like morbidity, mortality, adverse drug reaction reporting and preventing, pharmacists are doing a massive impact on these outcomes. And I think when you break down the pharmacy operation, you'll find that you have, for example, clinical pharmacists have a major impact on patient outcomes. Their interventions, their recommendations, their advice to physicians regarding dosing, whether renal dosing and the therapeutic drug monitoring, it significantly impacts patient outcomes like morbidity, mortality, length of stay even, like Dr. Lena mentioned, the OPAT system, for example, using, especially like what we did in our hospital, we used elastomeric pumps who have very clear rate and flow, and it significantly positively impacted our length of stay, our bed occupancy rate. And it was a pharmacy-led project. So I think and Dr. Anas and Dr. Abdurrahman can probably
let me
add
put
more.
it like this. Maybe I will give a very challenging question, statement, and I'll let you refute it, maybe. Most of the pharmacy leaders, directors, me included, we talk about, maybe because it's a complex processes and we are not in the frontliner usually, or we don't think about ourselves as a frontliner, although we are sometimes. So we almost always, I'm not going to say always, put process outcomes. Yani, for example, how like the KPI about the chemotherapy, about the turnaround and delivering patients. But we don't link, for example, even about the OBAT. It's obvious that the OBAT will decrease the length of stay. But do you, as a pharmacy leader, do you have a dashboard that says how much of your OPAT is linked to your length of stay? Do you need to increase the OBAT? Do you need to decrease it? Is it linked to the cost? Is there a threshold where you are increasing, for example, you have 100 patient OBAT, is that increasing the cost?
Absolutely.
Or not?
Absolutely. We presented this because, the OPAT, we started with the OPAT very lightly because the pumps, to be honest, I mean, if you look at the cost, the pumps are expensive.
Yes.
So it may cost more to send a patient home on an elastomeric pump versus an electronic pump, where the nurse goes to the house, home health care or medicine care at home, whatever you may call it. It's more costly, but if you look at the cost that it prevents, so you don't need to send a nurse home to the patient. The patient is trained in the hospital while he is admitted at the room, trained on, and the caregiver, the mother, the father, or the spouse is trained on how to manage the pump, how to disconnect the pump. So we actually presented the outcomes of the few patients that we had the trial on, and it amounted up to about 1.2 million riyals saved over the year, the trial period. So yes, absolutely, it was a significant intervention. It was a very clear benefit from the project. So we did actually calculate. We had very clear, statistics and data, the number of patients, the length of time that we saved from staying in the hospital to being treated at home, and we factored in all the costs that we prevented, the bed occupancy rate, the bed cost, the nursing time.
Sure.
And it was a significant saving.
Not that I don't believe that the pharmacy efforts is not full of outcomes. The literature already proven that we We reduce cost, we reduce even mortalities in some settings, we reduce hospital stays and everything. But it doesn't mean that it's published, that it is in your institution. So day to day, week to week, month by month, quarter by quarter, we should put a KPI for us to make sure that we are aligned to this published data. Are we there yet or not? Sure. So for me personally, I think we are more focused on the process. Do you agree or disagree with me on this? We are more focused on the process rather than trying to link our processes with the outcome. If you have thoughts, how can we do that? If you agree or disagree with this, to a certain extent, maybe. Maybe our experience is less mature than yours. But I think maybe we can do this. If you have any thoughts, how can we do that? Yes.
Well, I agree. Briefly, I agree. Because demonstrating clinical outcomes is harder. It's multifactorial.
Sure.
We are part of a process.
Sure.
We cannot say that only our work did this, because there are nurses on the picture, there are doctors in the picture.
Sure.
So it's, yes, we are part of this, but we cannot put it as, I wouldn't say we cannot, but it's not easy to put it as a pharmacy KPI.
Yes,
only
because
pharmacy.
you will own it.
It's a hospital KPI maybe.
Yes.
Pharmacy contribution.
And I think the initiative or that Dr. Lina mentioned, the finance and pharmacy, or pharmacy and finance committee. So it's a committee that owns this process, but it does not blame you. It doesn't give you full responsibility on the process. So I think
on the clinical, on the operational, yes. On the financial, maybe yes, but not on the clinical alone.
Yeah.
However, safety part, which is a clinical also, yes, you can claim more responsibility for, especially when it's related to medications, adverse drug reactions, medication errors, measurement, etc. It's very, very important to have KPIs for that. And I think we all do. However, I think it's always one of the challenges in setting KPIs for these, because it's always that setting the right denominator.
Yes.
Because when you say it's a percentage, it will be, you will see 0.0003% of all prescriptions. It's not easy to distinguish.
Yes.
So it's always very important to have the right denominator that will show you any, outliers. Clearly. So also this is part of the art of KPIs, is setting the right denominator for your measurements. And this will extend also to antimicrobial stewardships as well. Setting the right denominator for, is it patient days, defined daily doses per patient days, etc., etc. So also this is very, very important. I think, yes, safety, we can claim more responsibility for.
I think cost also.
But efficacy is multifactorial, and we are part of it. Yeah.
Yes. What about you, Doctor? Do you think, for example, if we are, the adverse drug reactions, the most common KPI for adverse drug reactions, and I think all hospitals, is number of adverse drug reactions and the severity, maybe the percentage of severity or how much we are doing any severe harm. But how can we improve the adverse drug reaction KPI to make it more linked to, for example, care or cost or harm or safety?
I would like to add, and really thank you for pointing at the reporting, because we've noticed this. We are analyzing the IDR report, and like on daily basis, and every quarter we need to do the report. And we noticed something, the areas that usually they are the best in reporting were the oncology nursing unit, because they see most of the infusion reaction in the infusion center, but they are very well trained to report, to manage, and maybe to prevent, like, so we did like kind of MUE about it.
Yes.
And then we realized that the gaps we found by nursing and physicians and the order sets I mentioned earlier. So we improve our order sets, we improve the nursing knowledge, and then we improve the number of maybe less kind of infusion reaction related specifically to paclitaxel. But now, while you were just opening this topic, I was thinking, how can we relate it to ED visits from the oncology services? Then that will be kind of outcome measure that we see if all the things that we have done really resulted in improvement in the outcomes. There is one thing about the OPAT. I was fascinated when I was reviewing, all these articles before I prepared to the presentation. And I found that there was an article talking about the OPAT, how much they saved, but there was one thing I didn't share because of the time. Definitely, the OPAT having a clinic and bringing the patient to the ED visit to get the antibiotic was more cost effective than the inpatient hospital stay. But they were mentioning something interesting, that they found that ED visits, not the clinic, OPAT clinic, is more cost effective. And I was a little bit surprised about it, but this is what they show. So maybe
maybe not dedicated not dedicated nurses and staff for the clinic.
For me, I would love to. I think it's more effective to have a clinic, have experienced nurses, experienced physicians dealing with this patient. But that was actually the financial results.
Yes.
But you can link it to readmission of these patients who were admitted for this infection. So the way you were thinking is very, very important. I think I learned a lot when I was preparing this presentation, is that not just the process, it's the outcome. So if you want to build a KPI, look at the outcome, not just, if your pharmacist did this or not. No, the patient get the benefit or not.
Yes.
So thank
you. So just an exhibit is one of the examples that we did, for example, for adverse reactions, we just wanted to increase the reporting, and I'm very happy that you brought this up, because this is my next point, is about documentation and building data and making sure the quality of the data for the KPI. But just before I leave this point, is when we just say, I want to increase the number of adverse reactions without linking it to specific, maybe I will waste the efforts in fishing for adverse reaction reporting, rather than, for example, focusing on the adverse reaction reporting of high-risk medications, for example. So if I would say for the pharmacists, or even for physicians, or for nursing, we are focusing on reporting the adverse reactions for anticoagulations, for example, in the hospital. And in 2 or 3 quarters, we see how much of this resulted in the incidence of bleeding inside the hospital. And then we do initiatives or projects to decrease this. And I think this is the systematic way we should do our KPIs. Unfortunately, we just collect data, and in believing that the published data that says that we have to report adverse reactions, and reporting of adverse reactions will reduce or will increase the safety of the hospital, but not individualized. So going to the documentation part, I think, or system documentation, how do you think our pharmacists in general, I think we have some from the ministry, we have from even outside Saudi Arabia, and even from universities. What do you think the readiness of the systems in general in supporting KPIs related to pharmacy? Do you think the systems, the HIS systems, are built to help us in this? I think a lot of when you start with the HIS, they will automatically calculate the length of stay, for example. The readmissions, they have already built in even DOT sometimes and DDD. But when you talk about waiting time, you have to create it by yourself, or dashboards. Share with us your experience in talking to HIS, or even if you want to collect it manual, what is the struggle you face while collecting the data to do the KPI? We'll start with Dr. Hamas.
Okay, so of course, electronic systems are there to help you assess your operations. What I will always say is if you get a system that helps you, that's a good system. If you get a system that needs help, so you need to intervene, then that's a poor system. Unfortunately, and I don't want to talk politics, but most HI systems in the hospitals play a very poor role, and when you get when you need any statistics, unfortunately, they don't really help you. A good way, for example, for ADRs, we're spending too much time on the ADRs that we identify and we document.
Yes.
We're
What
not
about
looking at the ADRs that we missed.
Yes.
A good way is to establish a KPI for those ADRs. So what we did in our hospital, for example, we identified triggers for ADRs. For example, if you suddenly see a patient receiving vitamin K, for example, so that's a trigger. So you look in. It may not be something significant. Maybe the patient's for any reason, liver issue but look into that. It may be a warfarin, for example, a high INR that triggered this vitamin. So that's an ADR right there. If you suddenly see a patient receiving adrenaline, for example, it may be an overdose of a beta blocker or something. So we identified certain triggers, even not necessarily medications, even trigger procedures as triggers for an adverse drug reaction. That's one way where you can actually take, for example, how many triggers were identified that were actually triggers for an ADR that were not reported. So you can use your denominator and numerator and take a percentage, for example, and use it as a KPI. That's one way we did it. So we're looking and encouraging ADR reporting.
What about Dr. Anas? What about, for example, when you tried this chemotherapy? Do you think it's...
Well, I agree with Dr. Nabil that systems are not perfect. However, I still also believe that they can contribute, but they will need some effort, especially in the beginning. So to set the, let's say, the whatever equations in the background for the dashboard to be fed automatically every month, for example, will take a lot of work in the beginning. But once it's done, and we have many examples, for example, in our hospital, where we have worked on dashboards. It took sometimes a couple of months, but when they're there, every month, on the 1st of December, for example, it comes to your email, automatically pulling the data from the system and putting it into this dashboard. So it's very helpful. And of course, now with the revolution of AI, this will even make it more easier and more also maybe smarter to be done. So I believe there is a big role for digital tools and technology to play in making KPIs capturing and monitoring much more efficient. Because now it's one of the challenges is the time needed for documentation. So when this is done more and more autonomous way, this will make it more robust and accurate.
Yes. I would like to add that our experience with the informatics team, our colleagues in the informatics team has been very successful. And of course, all the time there is room for improvement. I've been chairing the Clinical Pharmacy Council at Sahha hospitals in the last 2 years. And we sit together. Sometimes we give them the idea and they tell us the solution. Very helpful. And there's, the tool I was talking about the clinical pharmacy intervention, it was not just created like this. There was a form that we were working on it, and once we started this initiative, we identified gaps in the documentation. We try to make it as much as easy, as friendly to our clinical pharmacists so they can report in it. Because we want to encourage documentations. Regarding adverse event management, we build order sets. Without their support, we wouldn't be able to build this order set as standing order. So once the physician is writing rituximab for non-oncology, I'm talking rituximab for some of the rheumatology disease, in the same order, you will see a set of pre-medications and set to the standing order of hypersensitivity. Without the support of a clinical pharmacist working with the informatics, we wouldn't be able to do this. So I think there is a great help from them. And all the time there is continuous improvement. Just make your system flexible that they can accept your ideas and they can work on it, and then you can test it, and then hopefully there is no one like perfect solution, but we're working with them all the time and they're very supportive. I think you need to involve informatics and all, like with your clinical teams. This is something I recommend.
I agree that our HIS sometimes have some difficulty to obtain KPIs, and unfortunately that one of the most important things to have or to determine a KPI is to be a measurable. So unfortunately, a lot of important KPI, we avoid to measure them because they are non-measurable in our HIS. So working with the HIS team and health informatics team is very important. And I have one case regarding the clinical pharmacy intervention. Previously, we used to put it in Excel sheet. Then we tried to present it for the higher administration. The issue was that they are not accepting outside resources like an Excel sheet or other dashboard. So we worked for almost 2 years with the IT team just to have a tool of clinical pharmacy intervention to be linked with the medication in the HIS. So alhamdulillah, last month we finalized this stage and we start doing documentation and keeping our KPI with the clinical pharmacy intervention linked with the medication ordered in the HIS system.
Very good.
We already finished our time, but we have one question from the audience, and I would like, for example, Dr. Hamas to answer about it just in 30 seconds. How different how is different pharmacy KPIs from the executive management KPIs, and how can we bridge? If they have their own KPI, how can we have our KPI that's aligned with it?
You mean like the hospital executive management?
Yes.
Well, I mean, if you look,
for example, if the hospital has patient satisfaction as how is it different? We have patient satisfaction, they have patient satisfaction. What is it?
It's totally different. It could be actually in two opposite ways. For example, a patient may be very satisfied with the waiting time for the clinic, but totally dissatisfied with the waiting time in the pharmacy or lab or X-ray. So, Dr. Anas mentioned that the KPIs should be always aligned with the vision of the hospital, and that's given. That you can't have KPIs that contradict the vision or the mission of the hospital or the core values of the hospital. But they may be, I said, maybe totally different. Patient satisfaction is something, it's not just at the level of the hospitals, at the level of the MOH.
Yes.
We receive feedback from MOH about patient satisfaction, about patient complaints, not just how many complaints, like how fast they were closed and how is the patient's agreement to the closing of the complaint. So it's definitely aligned. All your KPIs should be aligned with the strategic plan of the hospital, because basically your KPIs are designed or built based on your operational plan, which is aligned with the strategic plan. So your value drivers, again, which are the cornerstone or the seed where you actually grow your KPIs, is aligned with your values. So definitely they need to be aligned.
Okay, with this we conclude our session. Thank you for our panelists. If I have 1 more hour, I would talk non-stop. Thank you so much.
Thank you.
Ladies and gentlemen, this brings us to the conclusion of session 11. We would like to extend our appreciation to our speakers for their valuable contribution insights through this session. It's our honor to invite Dr. Badr Al-Ghamdi to kindly present the recognition to our speakers. It's our honor to invite Dr. Rashid Al-Ghanem to kindly present the recognition to our speakers. Dr. Alina Wahba. دكتور نبيل خماس. دكتور أنس حمد. دكتور عبد الرحمن العنزي. Ladies and gentlemen, we truly appreciate your time and thank you. We will see you tomorrow at 12 p.m. Thank you very much.
حضورنا الكريم، ها قد جاءت اللحظة الحاسمة. اليوم لا نعلن عن أسماء فقط، بل نعلن عن حصيلة جهد ومنافسة مميزة في مسابقة صيدلية المستشفيات، مشاركة رفعت مستوى التحدي وأظهرت نماذج مشرفة من التميز والابتكار. ويسعدنا أن نعلن عن 10 المتأهلين للجولة النهائية، وهم نخبة استحقت الوصول لهذه المرحلة. مستشفى الدكتور سليمان الحبيب، ومدينة الشيخ طحنون الطبية بدولة الإمارات العربية المتحدة، مستشفى القوات المسلحة بالجنوب، والمركز الطبي للجامعة اللبنانية الأمريكية مستشفى رزق في لبنان، تجمع مكة المكرمة الصحي، مركز السلطان قابوس المتكامل لعلاج وبحوث أمراض السرطان، وتجمع جازان الصحي. مستشفى الملك فيصل التخصصي بالرياض. تجمع المنطقة الشرقية الصحي. وأخيراً وليس آخراً تجمع حائل الصحي. في الختام نتمنى التوفيق لمن لم يحالفهم الحظ هذه المرة، ونثمن كل مشاركة كانت جزءاً من نجاح هذه المسابقة، ونراكم على خير غداً بإذن الله.